presentation, please. Can we start playing?
Good afternoon, friends. I have been given the task of opening the show on the MIS workshop on tubular retractor systems. So let us take a quick look at the basic concepts. I'm sure all of us here know the lumbar spine in and out. So let us take the next step of going through the certain key factors of the relations, that when we are dealing with an L4-5 disc, the root that tends to exit at that level is called the exiting root, which is the L4 in this case, and the root that passes through is the traversing root, and it tends to exit at the next level, which is the L5 root in this case. The spinal canal stenosis tends to be at is divided into the central zone depending upon the area of stenosis. Anything lateral to that would be the far lateral zone or the lateral recess, or it is also called the subarticular recess. The area between the pedicles where the foramen is there is the foraminal zone, through which you can get a foraminal compression, and anything lateral to that is the extraforaminal area. You may get a disc prolapse depending upon the location of the disc. It may be a central, causing a compression of the chordae equina, or it may be a posterolateral variety, a foraminal disc, and a far lateral disc. If you take a look at this image, the L4-5 posterolateral disc tends to compress the traversing nerve root, which is the L5 in this case, whereas the foraminal and the far lateral disc are likely to compress the exiting nerve root, which is the L4 nerve root. Cambin in 1987, almost a decade before Foley, developed the arthroscopic discectomy, and subsequently Foley expanded his MEDs to the matrix system using microscopes, and then the TLIFs. Taking a quick look at Kevin Foley and his system, they developed the microendoscopic discectomy using the classic posterolateral approach, and then added the matrix tube system. Anthony Young popularized the transforaminal approach, which was initially propagated by Cambin, and Jean Distando developed the endospine surgical set, which however has been quite popular among the neurosurgical community. Later, Sebastian Rutten and Martin Comp developed the full endoscopic technique, which initially was developed on the transforaminal route, but then they added the interlaminar option, and they have published a significant number of papers on it. So if we take a quick look at the type of approach, the posterolateral approach is classically used for the open surgeries by Distando and the interlaminar endoscopy. The posterolateral approach is used by the MIS system, the tubular systems, and the transforaminal approach by the Young's system. The interlaminar area is the target here, whereas in the Young's system it is the Cambin's triangle, which is basically a triangle bounded by the superior edge of the transverse process, the exiting root, and the traversing root, and the superior articular process tends to be in the floor of this triangle. Comparing the four options that we have in front of us, all of these have a learning curve, which may vary from about 20 cases to 40 cases, with the transforaminal having a slightly higher number of cases, but the curve is slightly steeper and is easy to go through as compared to the full endoscopic curve. All the systems can be used in the cervical spine, but the latter two require slightly different and narrower gauge of equipment. Regarding the versatility, except the transforaminal, all the other three can be used at the L5S1 levels. You can do single level decompressions, multi-level decompressions, over the top decompressions, and remove tumors with all the other three, and hence only the transforaminal system has got a certain degree of limitations. The tubular variety as well as the transforaminal can be used in conjunction with the pedicle screws to effect MIS fusion surgeries. and both these two are quite user-friendly compared to the other two. That leaves us to one question that is bugging our mind, the eternal question asked by all Indians: kitna deti hai? The tubular system is quite cheaper compared to all the other three, which require a significant amount of investment. Now, if we take a look at the tubular dilator system, this is the array of tubular dilators that are needed for accessing the spine, along with the tubular retractor and an articulated arm to hold it. If you're using the endoscopic option, which however is become redundant, you may use a fiber optic system with light source, or you may use magnifying loops with headlights, and perhaps the best option is to use a microscope with the recording camera. The indications are standard posterolateral disc prolapse, an extruded migrated lumbar disc, foraminal disc, a synovial cyst without any instability, unilateral or bilateral lumbar canal stenosis. You can extend it to the cervical spine and do a posterior cervical discectomy, as well as removal of osteophytes, and can be used in conjunction with MIS fusion surgeries. Certain large central discs such as these are best not done in the initial series. Large ones causing cauda equina are also best tackled open. Same goes for the multi-level disc prolapses, which may require an open surgery. Bilateral severe lumbar canal stenosis with a constitutionally narrow canal is best tackled open rather than to undertake a facetal removal during surgery. There are significant advantages. Instead of a large incision such as this, it requires only a tiny, less than an inch incision, which leads to enhanced cosmesis. There is reduced muscle dissection, reduced blood loss and pain, early ambulation and discharge to home, early return to work, and the recurrence can be tackled in a similar fashion. The learning curve is there, but which is there with all the systems. It does require specialized equipment, slightly increased cost sets off the reduced hospital stay by the patient. Although some authors have claimed a slightly increased risk of dural tear and root injuries and recurrent disc, this has been shown to be statistically not significant and has been unsubstantiated by other authors. The approach is a classic paraspinal intramuscular approach. The laterality of the incision varies depending upon the procedure. It may be 1.5 to 2 centimeters for an MIS discectomy, whereas for a MI TLIF, it is about 3.5 to 4 centimeters lateral depending upon the patient. Certain skin markings are needed before proceeding, and then there are various areas which needs to be targeted, and I'm sure Vishal will take it up in greater detail as we proceed. The docking point for the MID discectomy is the classic edge of the inferior lamina of the upper vertebrae. For the MI TLIF, it is the superior articular process of the facet joint. So once you insert your first dilator, then you do a sequential dilating and develop a path through which you can eventually go in and have in your vision, you will be able to see the lower edge of the upper vertebrae, the medial edge of the superior articular process of the lower vertebrae, and the superior edge of the lower vertebrae. So this is your classic vision which you are going to see through the tube, and it has actually become quite a blessing for the OBs, because to visualize an inch at the bottom, you otherwise require a 4 to 6 inch incision at the top, whereas with the tubular retractor it can be very well managed with just a single 1 inch incision at the top as well. Certain tips to avoid complications: do not use a guide wire, avoid plunging with the dilators, a meticulous technique is needed. Bayoneted instruments allow visualization of the area within the tube, so prefer to use them. Use fibrin sealants if a duodenectomy occurs, and do not hesitate to convert to open surgery if at all you see the spaghetti rolled out. Thank you.
So that was a quick overview of the other systems that are available for the MIS endoscopic as well as the tubular discectomy, and then eventually you can progress on to the greater number of surgeries that you want to perform through the tube. This was pretty basic. Is there any questions that have been generated by any of the panelists or the delegates?
There are no Q&A or there is nothing on the chat also. So I think we can, if there are no questions, we can go to Vishal's talk now.
What perhaps we can do is we have a few minutes of discussion left. What we can do is just have a quick check amongst the panelists that besides all of us here are the tubular discectomy option in performing the tubular discectomy, who else also undertakes transforaminal or full endoscopy? Does anybody do that? Like they use two systems, or do they use the only system that they are trained with? Guru,
well, I have used
would you like to answer the question?
In the past.
Yes.
I had a young scope, and
right.
I've given it up because I had a very terrible recurrence rate with the transforaminal. So the only time I use it is for an extraforaminal disc. Otherwise, we don't.
Okay. Anybody else?
I've used transforaminal system quite often in the past. So, but nowadays, more and more we are doing.
Start your video.
Yeah. So nowadays, more and more we are doing an interlaminar endoscopy, especially L5S1. Whereas on L45, preferentially we try to use a transforaminal system in most of the cases. More and more nowadays we are progressing, at least for lumbar disc. We have not progressed to a stage where we are doing a lumbar canal stenosis decompression through a endoscope, but at least discectomies we are trying to treat more and more by endoscopic method nowadays.
Okay. Vishal, just adding to what you just said, I have been doing the transforaminal, not the transforaminal, I've been doing the tubular discectomy for a far lateral disc. And if you go on to the recent literature, they have shown that there's a change in technique. Initially, the docking point for the far lateral disc using a tubular dilator was the pars of the vertebral body. But then there is an article which has shown that if you target the superior articular process, it is slightly inferior, and then go proximal to it, then you can very well do it through the tubular detractor. And I have done quite a few cases with that, and I'm very comfortable. Patients are happy. The incision is slightly larger than the one that you probably used for the transforaminal technique. Here, probably it's a 17 or 18 gauge tube, and so the incision is going to be about an inch. That's perhaps the only difference that I would like to add. Any more questions? Anything anybody wants to add before on? This is like a perspective about the general systems, all around systems. And except Umesh, if nobody else is doing any endoscopy, Umesh, does it require a lot of investment for adding on and a lot of training and a learning curve? What did you experience for jumping from to the endoscopy?
Well, investment, of course, yes. And especially now interlaminars, using an interlaminar endoscopy, RF becomes essential. Though you can do it without RF, but to coagulate the muscle to to achieve some hemostasis, it significantly takes away a lot of your time. We have done it without an RF earlier also, but RF makes your job very easier. So again, the investment of RF is significantly more. There are Indian systems available, but probably they may, we can try it out. I don't have any personal experience using the Indian systems. So what we have is a Wolf RF machine. So it gives excellent results as far as the coagulation and all is concerned. So definitely investment is required, but if we are treating adequate number of cases, and if we want to progress or enhance our learning curves or the spectrum of diseases that we are treating or spectrum of techniques we are using, so naturally, that is something that we will all have to do at some point in time. But as we see, I think over a period of time, the investments also are coming down. We are actually getting a lot of offers from all these companies in order to, so that more and more people buy these equipments.
Right. Okay. So
Vishal has got a very
what I just
smile.
No, it is between me and him. Something is happening.
Oh, I agree. Investments. We have a
basically,
complete wolf scope, and we try to do it, but somehow, I guess, in my hands, the recurrence rate was nearly about a third of the cases came back with larger discs because the analotomy required to go in the in and out view. I was very uncomfortable. In fact, one of my boss, my MS examiners, had his transforaminal discectomy decompression done by the pioneer in the field, and he ended up with a foot drop, which we had to go down and revise. So since then, I've been put off. My young scope is lying like a family heirloom because my wife refuses to let me throw it away. It cost a lot of money in 2006. And we have a complete endoscopy system. One of my juniors does occasionally. I do a very rare extraforaminal disc, which a tube will probably not get so well. But otherwise, no, tube's the way for me.
okay. I think we are heading for the time limit. So can we have the next video session by Vishal?
Okay. Talking of minimal access tube requires thorough knowledge of anatomy. When you do an open surgery with a retractor, the maximum you can see is this inside the canal. Whereas when you're doing a tubular surgery, your vision is greatly enhanced. If you're not happy with what you're seeing inside, you can always dog the tube from the other side. Well, if you're oriented as a good spine open surgeon, you would obviously be a good candidate to move up the next step to being a minimal access surgeon, because all you see is a bird's eye view of the same view that you would see in an open surgery without the trauma and butchery of the same. Well, the guide wire and the orientation has to be straight. As you can see here, your tube should be docked in axis of the disc that you're wishing to address. But your entry, unlike the midpoint, is about 3 to 4 centimeters lateral in an average size person. However, if the person is thinner, you may want to take a medial entry. But if the person gets fatter, as we see most of our patients, then you will go more lateral and lateral. I'll come to that point later. Well, that's the view of a patient, head end, foot end. That's the midline of the patient. What I've marked here are the pedicles, as I can see on a C-arm image, and that's the disc I wish to address. That is at the L4, L5 level. Well, if you have to do a decompression, I would dock my tube somewhere here inside. However, if I were to do a fusion at this level, I would dock a little more laterally. The reason for this, as you can see here, this is where I want to dock in a vertebral body for doing a decompression. That's what you can see here is the inferior edge of the lamina and the ligament of flavum. However, if I want to do a transforaminal fusion, that's where I would want to dock over the facet joint, excise this facet joint, and gain access to the disc. So this is one thing that you got to understand when you start your decompressions. So your target has to be very, very focused. You cannot afford to be off the area of interest that you want to go into. When you put in your dilators, after a small incision, a dilator is inserted. The innermost dilator has to dock on the bone, and it has to be moved in all the direction. It works like a periosteum elevator that's going to take the muscle off the lamina as well as the facet joint. You have to serially dilate each time, firmly holding the dilator on the lamina and the facet joint and using it to erase. As you can see in this video, when I'm trying to access the L5S1 through the serial dilators, I keep moving them, go down to the bone, one hand holds it to the bone while the other one opens up it all over this place so that all the muscle is erased off the lamina, off the flavum, and you get a better access. So you've got to do it that way. Once the final tube is put in, Always check the position. One of the most common mistakes made is while accessing the L4 or the L5S1, because the entry point is the same, except that in an L5S1, instead of docking straight as you would dock for an L4-5, you dock at an angle. So if your anesthetist has done a head high while you've been out to scrub, or if your assistant has not informed you about the position of the table, you are very easy likely to miss your level. So once you dock, that's the orientation that you would have. That's the medial, that's the lateral, that's the foot end, and that's the head end. What you can see here is the lamina. That's the ligamentum flavum. This creep of muscle, especially in this case, I haven't addressed because I wish to do just a decompression in this area. However, if I want to address a larger area, it is always better to cauterize this muscle and then try to take it out with a pituitary ronger or a kerosene. Because if you don't cauterize and try to take it out, this is going to retract inside. And if it retracts inside, it will be very difficult to get the bleeders off. Well, a focus docking here, it's a fixed tube that I'm docking for this disc. As you can see here, it is docked right across that area. This is the representative X-ray. However, this is what I would dock in for a TLIF. Here, I'm docking over the facet joint. That's what you would see in real life, and that's the schematic drawing for the same. A few tips: if you're reaching the L5S1 level, then L5S1 disc is going to be at an angle, and it is going to be more cephalocaudal. So to work, rather than working at an angle like this, it is better to give your patient an head high so that the disc is more vertically oriented and you are able to use your instruments in a straight line rather than at an angle. However, if, as seen in this case, this was a grade 3 listhesis we addressed with an MIS surgery. So in this case, the slip was so great that even after putting a patient in the head high, I still have to work at an angle. The way to see that you get it correct, as you can see here, my tube is docked at exactly parallel to the end plates. That's the only way to be able to reach your pathology. In an extraforaminal disc, your tube has to be more lateral and has to dock just lateral to the foramen with the medial edge sitting on the pars. So that way you are able to see inside the foramen and address the disc. I will not be going into the decompressive procedures because subsequent talks will handle that. But this is one thing you got to remember. This is the best way to handle an extraforaminal disc. In fact, I prefer this to pure endoscopy because this gives you a good view of the foramen and you're able to take care of the pathology. You can also do it in the cervical spine. As you can see here, this herniation, it addresses lateral herniations, osteophytes, and of course in unifacetal dislocations or one level or two level fusions of the lateral mass. MIS is a very good way to do it. Here, however, you have to use a K-wire that will dock on to the level of the pathology, and then you serially dilate under a C-arm. You don't do this blindly as you would do it in a lumbar or dorsal spine because the anatomy is extremely small and you're very likely to slip out of it. You can see here, this is a schematic drawing of how screws get put in, and that's the end point of this. The only thing while docking you have to remember is to take down the spinous process, and the entry point is at the midline because you're addressing a lateral pathology. So you go down the midline, take out the bifid process, and then dock your tube. The same incision is used to reach to the opposite side if you wish to do it. It's extremely useful when you have a unifacetal dislocation that refuses to have a closed reduction. You can just drill out the facet and the whole joint pops into its place. If you wish to do lateral discectomy, this is the view we are going to get, and you need to dock a little more medially. Well, in special situations like this osteoid osteoma, just below the pars at the angle of the pedicle, we have used, you can do your docking with navigation. There are navigations that allow you to dock your tube. As you can see here, there's a projected image of my inner dilator, which then I know where it's going to dock. As you can see in this image, we've used an O-arm to navigate here, and through this 16 millimeter portal, we've been able to take that osteoid osteoma out. Thank you very much.
Okay.
I think, Subir,
Yeah.
Yeah, this talk was combined with actually my video. So we'll complete my video and then we'll take questions or discussion. Otherwise, we'll run out of time.
Okay. Okay.
Okay. So can we have my video? Good afternoon, friends. Myself, Dr. Gurura Sangondimat. I work as senior consultant and unit head at Department of Spine Surgery, Indian Spinal Injury Center. Today, we are going to discuss about tubular discectomy, how to go about it. My patient is a 32-year-old female patient who presented with back pain with bilateral lower limb radiculopathy since 4 months on treatment. Pain was left more than right. She had weakness in left foot since 15 days and hesitancy in urination. On examination, SLRT was 20 degrees, EHL and FHL were 3/5, sensory decreased in S1 dermatome, PAS and VAC normal. This is her MRI. She had this extruded fragment at L5S1. This is another cut. This initial part of video is going to be animated. So initial few cases, you can mark your levels, you can mark the midline, you can mark where you are going to take this incision on the paramedial side. And usually it corresponds almost 2 centimeters from the midline or 2 finger breadths apart from the midline. Usually I try to take this incision little medial as compared to normal where it has to be taken, because the spinous processes and muscles constantly tend to push your tube more lateral. So I tend to be a little medial as compared to usual. So once you mark your incision, you start dilating the muscles. I start docking my tubes or start dilating from the smallest dilator which we have in the set. I tend to avoid using guide wire, because inadvertently guide wire can enter into the interlaminar space and cause dural tears. So sequentially you start going on dilating the muscles, and then you go on wiggling your dilators so that to separate muscles from the lamina. So serially you dilate them according to the diameter of the tube you are going to use. These are all color coded depending upon their diameter. Once you are dilated completely, you use the tube. I usually typically use around 18 millimeter tube, and the length is determined by the there is a markers on these tubes to determine the length. So once that is done, you will attach your flexible arm to hold the tube at its place. When you do this, you have to preload the tube and take this flexible arm above the tube so that tube stays at where it is and it doesn't pop out, and allowing the muscles to creep into the surgical field. Once that is done, you will attach your light source, or you can use a microscope. So at this step, I would tend to put my finger into the tube and try to feel the edges of the lamina and the interlaminar space and facets. And invariably, whatever you might do, some amount of the muscles creep into the surgical field. You take it out from the you coagulating them with bipolar and with the pituitary rongers. Once that is done, typically you will see this is your surgical field. This is the head end, this is the foot end, this is medial side, this is lateral side, this is lamina, this is where the pars is, this is the facets, that is the interlaminar space. So here you start widening the interlaminar space depending upon the level. As you go at the top levels like L2, 3, L3, 4, you might have to cut more of the lamina and do more laminotomy. At the L5, S1 and L4, 5, you have to do a less laminotomy as compared to the upper levels. So here you start separating the ligamentum flavum from the undersurface of the lamina using curved curette, and then start taking down the lamina with the rongers. Typically, I use 30 millimeter diamond burr for doing this laminotomy in this procedure. But here, for the simplicity of the procedure, I'm going to use the Kerrison rongers. You can use 2 mm or 3 mm Kerrison rongers. So you have to be careful here, and you be aware that where is the pars. Inadvertently take down lot of don't take down lot of lamina and pars, causing iatrogenic pars slices. And then once you start widening the lamina, you start seeing more and more ligamentum flavum there. Once you do a superior widening, then you have to do a lateral widening of the interlaminar space by doing the medial facetectomy. So if you do a too little medial facetectomy, you will have to retract the nerve root too much, then which can increase your neurological deficits. So be sure that to do a ideal amount of medial facetectomy. So how to recognize the end of the medial facetectomy there? That is by seeing the edge of the lamina when you start doing the medial facetectomy there. So once you do the medial facetectomy, you will start seeing this yellow ligament, that is ligamentum flavum. Ligamentum flavum there. So a lot of people try to do a to go to the edge of the flavum and then try to dissect it from superior down. But typically I don't do too much of laminotomy, so I do a mid substance dissection using a number 3 or number 4 Penfield. And at this stage, I also make sure that there are no adhesions between the ligamentum flavum and thecal sac or nerve root. So I try to put my curette and try to make sure that there are no adhesions. Once you start taking down the ligamentum flavum or do a flavectomy, you start seeing the epidural contents, thecal sac, and sometimes you see a epidural fat depending upon the size of your disc. So the epidural fat is an indication that you are inside the epidural space. So if there is a lot of epidural fat, you might have to take it out by using a bipolar cautery or a hydrodissection or using a pituitary. So you be careful that when you pull this epidural fat, don't catch nerve root or thecal sac into your pituitary. So once you do that, you start seeing clearly all the epidural structures. That's the thecal sac. The nerve root is somewhere here. And so try to actually retract the nerve root. And at this stage, be careful that don't forcefully retract the nerve root. There can be adhesions between the disc and the nerve root. So be very careful. Try to separate these adhesions using nerve hook. And once you retract the nerve roots, so you see that underneath you start seeing the disc bulge there, and you start seeing these epidural veins. That is an indication that you are at the right place. So here, because it's an extruded fragment, disc starts delivering out itself. But then don't be enthusiastic. As soon as you see the disc, don't try to take it out, because try to take it out in one piece as much as possible. So use nerve hook to tease out the disc in one fragment, and then once it is out, you can take it out with the pituitary. So here I'm going to take this fragment out, which is has already popped out with the pituitary. But then here again, you have to be very careful. Don't catch the nerve root. And in initial few cases, you can ask your assistant to retract the nerve root and hold it away from the working field. So once that is done, you can see nerve root is nicely pulsating, and then you can see that second fragment is again delivering out itself, and then you take it out using the pituitary. So that's the suction retractor, which is very handy when you do these tubular discectomies. And then you take out all other fragments slowly. And then be sure that if there is only an extruded fragment to do a fragmentectomy, not to actually create one more annular rent to take out and enter into the disc and create an annular rent. I generally tend to do fragmentectomy, but if the annular rent is already visible, then I will go inside the disc and try to tease out all the loose fragments. Once your discectomy is basically the end stage of your discectomy is indicated by this bleeding which is coming from the disc, or you start suddenly having a epidural bleed there once the decompression is done of the nerve root. So try to take out all the loose fragments. If you're already entered into the disc, you can use a straight and forward pituitaries, and you can always do a hydrodissection using a saline to flush out all the free fragments. Once you are satisfied that you have done or taken out all the loose fragments, you have to check for the free mobility of the nerve root. So you can see that nerve root is very mobile and it is pulsating very well. So that's an end of your discectomy. Thank you. Subir? Okay. Yes. So do you have any questions there?
Yes. I have kept a couple of things for discussion quickly. So, Guru, two things. You did a very beautiful micro discectomy. Just wanted to add, do you ever need to use the burr for doing a medial facetectomy, or you are comfortable doing it with just your ronger?
No, I tend to actually use burr because it is more quicker and I have more control. I feel that how much I cut the medial facet or the lamina. So I tend to use burr, but because here I had to demonstrate it and everybody might not have the burr. So that is why I use ronger here.
Precisely.
But then I usually use
Right.
burr to do my discectomies and do a laminotomy and
The
decompressions.
only Perfect. The only important thing is that if you're using your Carrison, then the bite of the Carrison should be sufficiently big enough for it to catch the superior articular facet from beneath. Otherwise, if it's a regular sized Carrison bite, then it will not be able to do your medial facetectomy. And at that point, you may require to go back to the original thin osteotome and do an osteotomy of the medial facet. So I would encourage and recommend that all those who adopt the MIS tubular should eventually buy a burr because it is very handy and then it helps your surgery. And actually, during the MIS TLIF, it also is very useful. One more thing regarding your, yeah.
Actually, I because of want of time, I didn't record it in my video. So most important thing is in tubular discectomy or tubular decompressions or tubular procedures is to avoid as much as possible creeping of muscles into your tube. So you have to use special techniques to prevent that. One is basically wiggling or dissecting your muscles through the dilators which you are using. After each dilation, actually you wiggle it up and down mediolaterally so that muscles don't creep into your field, and always hold your dilators pressed against the lamina. And once you introduce your tube, I would always encourage everybody to preload the tube with your basically the flexible arm. Take your flexible arm above the level of the tube and hold it there and tighten your flexible arm so that your tube is pushed against the lamina. It doesn't pop out. If it starts coming out, then your muscles starts creeping from every direction into the tube, and then really surgery becomes messy. So I think that is one very important step next to the site of docking.
Okay. Just one more question quickly for Vishal. Vishal, are you there?
Yes, I'm there.
Good. You showed the use of a guide wire, which, however, is now becoming obsolete. Occasionally, to identify the needle, we did use a spinal needle, much more lateral to the midline, so that we just end on the facet. But do you still use a guide wire? And question number 2 is, you showed a beveled tube. So whether do you use a flat tube or a beveled tube? And
so
why?
it depends on what I'm doing. Guide wire is only used in cervical spine when we're doing a lateral mass or a jumped facet or one of the lateral discs that we are taking out. Because cervical spine, you have to use a guide wire, and only over that you can dock it, because you have to go. The guide wire skirts the bifid process, and then you knock off the bifid process and then put your dilators. Lumbar spine, we don't use a guide. In fact, nowadays we are more careful even while putting the smallest dilator inside, because that too, if you're not positioned correctly, and especially in frail patients, has the the nose is small enough to go through osteoporotic bone. So it's only after the second dilator comes into the picture that we really start dilating and holding it against the bone. As for tubes, it depends on what you're doing. If you're doing a extra foraminal disc or a foraminal disc, you need a beveled tube, because that the proud end of it is used as a muscle retractor while you're turning it and moving it. But otherwise, you can use a flat tube for most of your decompression of the lamina or TLIF. You would need a proper flat tube. So a TLIF, occasionally in a high grade TLIF we use an expandable tube. In a normal TLIF we use a fixed 22 millimeters. In very obese patients we use a lot of 14 to 16 millimeter cages. So sometimes a 22 millimeter fixed tube is not good enough to get that cage in properly. So in those cases we may use a 24 fixed tube. And for decompression, is a 16 millimeter tube nowadays that should be used, because 16 millimeter can be docked over the facet and just medial to the spinous process, whereas an 18 millimeter tends to sit on the facet and sometimes causes damage to the facet joint.
So the 18 millimeter actually leads to more creep of the muscle.
Yeah.
So if you have 16 millimeter, that's perfect actually. It just sits between the spinous process and the facet. Yeah. Beautiful. I think we are on time, and we should go to the next talk or the video by Shumoyu. Can we have the next video by Shumoyu, please?
Very good afternoon to one and all, and I'm very glad to be able to connect with you all virtually. Today, the topic that I'll be talking on, which is a video presentation, is about over-the-top decompression done through the minimally invasive tubular retractor system. So I'll just start with a little bit of the case. Okay. So this is a 65-year-old lady. She has uncontrolled diabetes, hypertension, Parkinson's. She's obese and complains of severe bilateral radiculopathy for more than a year, right leg more than left leg. So it's bilateral symptoms. And the symptoms are neurogenic claudication, where she can stand for barely 30 seconds, walk for about a minute. And over the time, it's getting worse. So these are her scan images. On the sagittal, we can see in the mid-sagittal cut that there's a lot of flavum thickening around L4-5, and the thecal sac is compressed. And when it comes to the T2 weighted axial cuts, you can see that there's severe stenosis here, and there's bilateral lateral recess compression. The flavum is hypertrophied, and these are the cause of the symptoms. So far, things that have been talked about is needle positioning, docking, or doing a tubular discectomy. But a part of the advanced technique would be when you have to do the over-the-top decompression, or what is a contralateral decompression. So over-the-top sounds like a fancy term, but in its essence, it's quite simple. It just means going over the top of the flavum onto the opposite side and doing the decompression on that side. So when we look at a ipsilateral work, we've docked the tube on the same side of the lamina. A small hole is bored out there, and then the flavum is removed. And if you need to, you can go to the disc also. This part makes a lot of sense to everyone who follows this procedure. But when it comes to talking about a contralateral decompression, how will I go to the other side and see the other nerve root, which is anterior to the thecal sac, is when the conceptual challenges start coming in. So if you just tilt the tube by about 45 degrees, you'll see that now the tube is facing where the other nerve root would be, the other side of the spinal canal. And to make this more feasible, the table would also have to be tilted the other way. And when both is done in conjunction, then it becomes feasible to do this procedure. So I'll jump right straight to the video, surgical video. And here, I'll just do the orientation. So on the right side where the mouse is, this is the head end of the patient. On the left side is the foot end. Away from us, towards the opposite side, is the midline. And this is where the facet joint would be. So you can see the interlaminar space here and some of the flavum, and this is the lamina. So once this is here and the soft tissue has been removed, and you can see the bone, the next part would be to bore out a small window into the lamina here. This, I'm sure, has been covered in the previous steps. So I can just forward this video a little bit. Okay, so now the boring is done, and you can see the yellow ligamentum flavum there. And this is the process of wanding. See, the tube has now it's released from the table attachment and it's medialized. The tip of the tube has now been moved more towards the medial end. And once that is done, the microscope is shifted back. The microscope is shifted back, and you can see a little bit more of the bone has come under visibility. This is the base of the spinous process. Using the tip of the burr, it can be put underneath the tube, and the tip of the spinous process is then shaved out. So this will then give us the access to the opposite side, which is needed to do the over-the-top decompression. So in a discectomy, if you're doing a tubular discectomy, the bony work is a lot lesser because all you need to do is just release the flavum on the ipsilateral side. But because you're doing a full decompression of the spinal canal, the bony work here is a little bit more. So we would be boring from the center. The lateral extent remains the same as you would in an open decompression. The medial extent is the base of the spinous process. Superiorly, we are going to up to where the ligamentum flavum attaches. So we want to bore all the way up. So this is the final ipsilateral bony work is done. You can see the ligamentum flavum there. Now, yeah. So now with the kerosene, I've bored out already whatever could be bored, and the remnant base of the spinous process is taken out with the kerosene. Before we start any of the ligamentum flavum work, it's very important to finish everything that you can do with the burr, because then you won't have to bring in the burr once the spinal cord is exposed. So here the ligamentum flavum has been detached from its superior attachment, and you can see a little bit of the epidural fat creeping into the visibility. So I typically put a nerve hook in at this point and release it completely from the superior and midline, taking advantage of the midline defect. And here you can see the ligamentum flavum is opening up. The little bit of the ligamentum flavum that generally does not come out by this releasing method, I would cut it off with a knife. So now the ligamentum flavum is released from the superior aspect, and the medial aspect is free, and it's essentially like a flap. So as you would expect, the next step would be to take the kerosene and do the ipsilateral flavectomy. So once the flavectomy is done ipsilaterally, the thecal sac can be seen. And now before going into the lateral recess, I would typically start the opposite side work. So this would require, again, loosening up the table attachment, putting in the final dilator, wanding the tube to the opposite side. So you see me doing that. So the tip of the tube is now facing the contralateral side. Now, once that is done, the table has to be rotated away. Otherwise, the angle at which we would be working would become too steep. So now the table is being turned away. And then once that is done, we would reattach or reposition the microscope. So this is a very crucial, a very good view. You can see the contralateral, even though we have done so much of work with the burr and the kerosene, there's still some bone there. You can see the superficial ligamentum flavum, you can see the deep ligamentum flavum, and you can see the epidural fat. All of these can be seen in different layers because we're looking from one side at an angle into the other side. Many people struggle with the concept of how to do a contralateral decompression. The reality is the ipsilateral work takes more effort than the contralateral work. So now with the kerosene, we're removing the final bit of bone on on the contralateral side. And then you can see the ligamentum flavum. And that's taken out the same way you would do in a standard case. And now you can see the entire circumference of the thecal sac is nicely seen and exposed. And once this work is done, you have to always remember that there's a deeper layer of the ligamentum flavum in the lateral recess. And with the pen field, I'm exposing just that on the contralateral side. Mind you, this is working on the opposite side. And you can see the ligamentum flavum there deep in the lateral recess. So then that is taken out with the kerosene again. So at this point, the work is completed. We have a complete thecal sac decompression, and we've done the lateral recess decompression on both the sides. And that will be confirmed with a nerve hook into the lateral recess. So here now we're looking at the contralateral lateral recess. I'm putting the dura retractor in. The root is underneath the root retractor, and the nerve hook is freely going into the lateral recess. And now the ipsilateral, we do the same thing again. And here you can see the nerve root, and we would retract that and feel the ipsilateral lateral recess right up to the pedicle and make sure the root is free there. And that completes the procedure. So this case was done essentially for this surgical demo purpose. And because of that, immediately post-op, I shifted the patient down to the MRI for MRI, and you can see both sides are completely decompressed. The nerve roots were free, and the MRI shows adequate decompression, and even on the sagittal the same.
Hello.
Hi, Subir, we can hear you.
Yeah. So that was a very nice demonstration by Shumoyo. So Guru, before we jump on to Shumoyo, there was one question for you in the chat box, whether we can, instead of going through the ligamentum film the way you showed, can we detach it from the upper lamina? So would you quickly take that?
Yeah, definitely. I just read that question. Definitely, it is safer to start from superior down, that go to the inferior edge of lamina or the superior edge of the ligamentum flavum and start taking it down. But then to do this, you might have to do more laminotomy, and then you have to cut more lamina for that. So for initial few cases, till you get experienced and you get oriented with your tube, you can do it in a usual way, go to the inferior edge of lamina and start taking down your ligamentum flavum. But then once you get experienced, once you get oriented, I prefer to do it mid-substance dissection of the ligamentum flavum, because it requires very minimal laminotomy to be done. So this is not about how much bone we are cutting, because this is about how much ligamentum flavum we are leaving it behind, so that we prevent adhesions for basically between thecal sac or decrease the fibrosis. So for initial few cases, you can do it in a usual way. But then if you get more experienced, you can start doing mid-substance dissection. But you have to be very careful when you do this, that put your curette underneath the ligamentum flavum and see for any adhesions between thecal sac and the flavum. So either way is, if you are doing at L5-S1, rather than going to the superior edge of the ligamentum flavum, it is better to go to the inferior edge of the ligamentum flavum, because there it is very minimally attached below the lamina. So for L5-S1, I start from inferior edge, and all others you can start from superior edge, or you can do a mid-substance dissection.
So just quickly adding to what Guru said, if it's a herniated disc extruded and slightly inferiorly migrated, then mid-substance dissection is going to be perfect. But the level of the disc, if you're going at the level of the disc, then you may need a little bit of a laminotomy, and at that point you can do the superior edge and inferior edge option. Shumoyu, that was an excellent demonstration. A very important thing you demonstrated it, and you did say that the table needs to be tilted. Now, the most important thing is that before you begin the surgery, you have to strap your patient if you're doing an over the top. So can you please elaborate that how do you strap your patients appropriately, because while turning sometimes they almost 20 to 30 degrees in the lateral position. So please expand on how do you strap your patients while before proceeding with your over the top decompression.
Yeah, so before we start the surgery, the whole team knows that we'll be, if you're using the tube, that I would be turning the patient around. So we use a chest strap and strap the patient on the chest and at the buttocks also. So and that's strapped to the table. Now we would be turning the table around 30 degrees, maybe a little bit more, because when you're doing over the top, the angle sometimes becomes so steep that unless you turn it up, your microscope will have to come down to that angle. So it becomes very difficult to work. So we do that. We use a couple of straps at the chest and at the buttock, and we strap the patient to the table.
Right. So that's a specific point for the OTT. You are not going to do that for your MEDs or your MITLIFs. But if you're planning an over the top, you have to specifically strap the patient. That is very important. One more thing was the use of a burr. I think unless and until you have a burr, you cannot do the over the top decompression, because the base of the spinous process is so thick. Despite at the widest bite of any Garrison, you cannot get the base off, and for that you have to have a burr. So the burr becomes, so for those who are graduating, like those who have started doing their MEDs, there always is a learning curve. So after the MEDs and the unilateral stenosis, before you embark upon the OTTs and over the top decompressions, I think to get a good burr is very essential. And would you like to comment on that? What burr do you use, and what is your experience with the burr, Shumoyu?
Yeah, I think, for someone who is transitioning from a microlumbar decompression, say they're doing a MLD, open MLD, but they're doing it through a hemilaminectomy, unilateral laminotomy and a bilateral decompression. So they can do it open first and then undercut the base of the spinous process through the open method under visualization, and then transition to a tube, because then that makes the learning curve much more simple. I use a 3 mm burr. I take it right across under the base of the spinous process, shave it out completely before putting the kerrison in. However, when you're docked ipsilaterally, like docked bang on, end on, and you're shaving it and then you turn a little bit medially, unless the bony work is complete, you can't really turn the tube completely. So when you do eventually do that, there will be some amount of bone that's still there. So that part a little bit you can take out with the kerrison also. Right. But I do this with the 3 mm cutting burr in the beginning, and then I shift to a diamond burr once we enter the room.
Okay, perfect. Yeah, Guru, you wanted to say something?
Yeah, Subir, actually, I just wanted to say, for everybody to have a burr is, I think, maybe in peripheral centers and all, it is difficult. So if they don't have burr, they will have to cut a little bit more of a base of spinous process to get access into the opposite side. Otherwise, you can do it with kerrison rongers also. That burr is not always, I say, mandatory.
I have found it quite difficult without the burr. That's why
I agree with Subir that you cannot use the kerrison rounder to do the over the top. A cheap way of doing it is to invest in a good quality 6 mm chisel, a bayonet chisel. Medtronic has it, and I've got it locally made. Instead of using a burr, you lose a lot of bone graft, especially if you're doing it in TLIF. So you have to start using a chisel at the base and go right through into the lamina, the posterior and the anterior edge of the lamina into the medial part of the facet on the opposite side. So you are going at the base, you chip through it right there. It has to be a chisel. A chisel is like this. An osteotome is like this. You use an osteotome, it's going to crack in the front. A sculpture will always use a chisel which is only angled at one side, so it takes away one chip at a time, so it needs some time to go there, whereas an osteotome, it can just bang through right in. So use a chisel, 6 millimeters, go across. That's a better way, because once you graduate from this to doing TLIFs, you'll get better bone graft.
Okay. I think we are running out of time. Quick.
One more, just a last comment is like, complete your all bony work before taking out the ligamentum flavum. So that decreases a lot of your dural tears whenever you do over the top decompression.
Yeah, Shumo did allude to that he finishes all his bony work before going on to the ligamentum. Perfect. Now let us move on to the next video lecture by Dr. Vikas Gupte. Can we have the next one, please, Vikas?
Good afternoon. Minimal invasive TLIF follows all principles of minimal invasive spine surgery. It preserves anatomy, midline structures, and paraspinal muscles without compromising on safety and efficacy. The indications for minimal invasive TLIF are well defined now, and it is a very safe procedure in failed back surgery syndrome. Certain situations where the procedure is difficult, and these are as indicated on the screen, on your screen. Like any surgery, proper preoperative planning is very, very, very important to look for certain points, and we use X-rays which help in assessing instability or disc space height, CT scans, especially to assess topographical anatomy, and of course MRI. Minimal invasive TLIF can be done using expandable tubular retractor or fixed tubular retractor, which I prefer, and with bilateral percutaneous pedicle screws. Now let's start with the procedure. Patient is positioned prone on a standard operating table on a bolsters. I prefer marking my doing surface marking of my pedicles before at the start of surgery. This helps me in passing skin entry point of pedicle, which is very helpful when I'm doing multi-level minimal invasive TLIF. Using a Jamshedi or Cook's needle, I cannulate pedicle first to pass guide wire, taking care not to injure or not to breach medial pedicle wall, as seen here. Guide wire is passed, checked on a C-arm. At every stage, avoid pedicle wall breach. I prefer passing guide wire in all 4 pedicles, checking them on C-arm. Then contralateral side from which I'm not doing passing a cage or surgery. Contralateral side, I pass percutaneous pedicle screws over a guide wire using dilator to split the muscle. This is followed by tapping using a cannulated tap. Once the tapping is done, screw is passed. I prefer using, for single level surgery, I prefer using Medtronic sextant system. Matrix sextant system. The screws are passed, towers are checked, and using a sextant, rod is passed. This rod is checked whether it has passed through the tower. Yeah, it has gone through the tower. and then fixed with a cap. While fixing the cap, you can do distraction or compression, whatever is required. Once the opposite side pedicle screws are passed, I come on the operative side using a C-arm, and of course the position is checked. On operating side, using a C-arm, I identify the facet joint line and pass a K-wire targeting that joint line percutaneously. Over that, I pass various serial dilators are passed, which split the muscle and create a working channel. I usually prefer 22 millimeter dilator, 22 millimeter tube. Length of the tube depends on patient size. Working cannula is passed over a dilator, fixed to the side rail of the operating table using a plexi arm, which makes this working cannula very stable. Dilator's K-wire is removed, muscle creep is removed using a cautery. At this stage, I take a microscope, identify the facet joint. Now this is let me make you aware of the anatomy. This is the facet joint. This is a inferior facet of L4 vertebra, and this is a superior facet of L5 vertebra. And this is what we call it as a safe zone. At this stage, we do facetectomy. I prefer using a Carrison punches to remove the bone piecemeal. I start from the safe zone, remove the inferior facet first, piecemeal. This bone is preserved, this local bone is preserved and used as a bone graft. Some people do use osteotome, but I think using a Carrison and using a piecemeal, doing a piecemeal removal of the bone gives us more control on whatever dissection I'm doing and whatever I'm cutting. So I feel it is more safe. Inferior facet is removed and you can identify the articulating surface of the superior facet. At this stage, I identify the junction of L5 lamina with the superior facet, separate the ligamentum flavum At this junction, I start my dissection or removal of superior facet piecemeal. This helps me in identifying the root and which is lying just there underlying, and my dissection goes up to the medial wall of the pedicle. And then superior facet is removed. You can identify the superior wall of the pedicle there. Identify the dura and traversing root and clear up the soft tissues on the side without retracting or without unduly retracting root and dural structures. You can identify the disc space there, which I am clearing off using a bipolar cautery. That's the disc space there. Once the disc space is identified, I do discectomy. Disc space preparation is a very important step in any fusion surgery. I use various curettes, shavers to prepare the disc space and prepare the end plates. Thorough disc space preparation is done. Then using a various sizers which are passed, we do assess the size of cage which is required. Once that is done, we pass local bone grafts into the anterior, into the disc space anteriorly. I use a funnel, locally made funnel, through which the bone grafts are passed and packed anteriorly. If the bone grafts are not adequate, sometimes I use bone extenders like hydroxyapatite crystals or G-bone. The grafts are packed into the cage, and cage is passed. I usually prefer peak cage. Cage is passed through the fixed cannula and checked on a C-arm, and this is the final picture after passing the cage. You can see the dura and traversing root and underlying cage. Then the pedicle screws are passed, rod is passed, screws are fixed in compression, and that's the final picture. Small incision connecting two pedicles through which the surgery is done. Few examples of minimal invasive TLIF. This one using a expandable tubular retractor, done very, very early in my career. Here the one side percutaneous pedicle screws are passed and standard pedicle screws are passed through the expandable tube retractor. Minimal invasive TLIF using fixed tubular retractor. This is the final picture. Spondylolysis listhesis. Canal stenosis can be tackled. Here we have done minimal invasive TLIF with the over-the-top decompression of the opposite side. Multi-level TLIF, 2 levels are done. And minimal invasive TLIF for failed back surgery syndrome. This is a very easy surgery, safe surgery for FBSS. To conclude, patient selection for minimal invasive TLIF will depend on surgeon's experience and skill, available surgical and imaging instruments, pathology, local anatomical topography, osteoporosis, and obesity. Thank you.
So that was a very elaborate demonstration by Dr. Vikas Gupte. And if there is a question in the chat box, no, I suppose it's an old one. Yeah. So let me ask you first question. If anybody, have you ever attempted to do the decompression first, put the cage first, and then put the pedicle screws like they do it in Korea? Dr. Gupte.
Few cases, yes. Not exactly for minimal invasive TLIF, but very tight lesion where distraction is going to be a little difficult. There I have done bilateral decompression first, done a fascectomy on one side, and then tried to put a cage, and so that reduction becomes easier.
So in spondylolisthesis case?
Yes.
Okay. So the question that one of the candidates has asked is that in case
what
of
I feel is No, what I feel is passing screws on the contralateral side first, spine becomes little stable. In very unstable situation, whenever you are doing think the spine is unstable, so reduction becomes little difficult.
So I'm sorry, I didn't get you. Reduction becomes difficult.
Passing the screws first on the opposite side, the spine, vertebra becomes stable. So your surgery becomes easier. Yeah.
Okay. So in case of listhesis, is it mandatory to reduce one side first, or can we attach the rod after inserting the cage? That's what one of the candidates is asking. So can you take that question, Dr. Gupte?
Yes, yeah. See, what I follow is passing the screws on the opposite side first, do the attempt the reduction, whatever reduction on table, without after passing the screws. Then do the main work, pass a cage, and then after passing the cage, you can loosen the rod on the opposite side to a certain extent and try to attempt a final reduction.
So for that, you will require a double assembly. So you have to have your Medtronic or whatever company you are using, wrap, have a double assembly available, so that once you have an assembly and you are not detaching your rod from one side, then you are using a second rod on the opposite side after passing the cage and then doing a reduction bilateral. So that is important. You have to have a double reduction instrument. Yes, Vishal, you would like to say something?
So Dr. Gupta is my guru. I've learned my TLIF under his guidance, but I have moved off from what he does. We have done about 56 high-grade listhesis, grade 3 and grade 4. The strategy for all listhesis is to first do the intradiscal work at our place. What we do is a complete release, go through one side, do a complete release, do the over the top, and only then try attempt reducing it, because there are large osteophytes in that area. So if you're trying to reduce it, the osteophyte is going to come into the way and crush the exiting root there. So the first thing is to, in a listhesis, is to go over the top, see that the opposite root is completely free, then come to the ipsilateral side, do your discal work, do a complete release, and then start putting cages. And when you put a cage, even in a grade 3 to grade 4, the smallest cage we put is 12 or 14, because unless you restore the height, that parallelogram effect is not going to come, and the listhesis is not going to reduce. Other thing is, majority of our patients are old and of poor bone quality. So to expect the screws to do the reduction, you are putting the load on the screw. A screw is a torque neutralizing device, whereas the cage is a load bearing device. So your stability and load bearing has to happen in the front. The screws just have to rotate. If you put the reduction stress on the screws, especially when you have not done the decompression, the chances of those screws plucking out or getting loose are very, very great. See, you have to understand, Dr. Gupta is probably just finishing 18 to 19 years of doing MIS TLIFs. So he has one of the largest experience in the country. So in his hands, what appears to be simple will not be correct for somebody who starts, who's in the starting phase, or who has just had 5 to 10 years of TLIF experience. So we try to do it the safe way. We do the interdiscal work first and only then put in our screws. Even when I use an O-arm, I've seen a lot of people who put in the guide wires and then put cages and then use the same navigation feedback to put the screws. However, if you have restored your discal height, which is to happen in a lumbar canal stenosis, your navigation goes off. So you have to acquire fresh images. So always do your intradiscal work and only then put in your screws is our strategy.
Okay, but just before we move on, Vishal, but what I have faced a problem is that when it's a grade 2 or greater listhesis and the disc height is completely collapsed, unless you do some distraction with the screws, you are not able to even get into the disc space. You are not even able to pass your dura. So how do you get that initial distraction for doing the disc work without putting screws?
I mean, it's a very different topic here for high-grade listhesis. Now, we've crossed about, in our place in the past 4 years, we've done documented 56 cases. We have presented it in one of the conferences. as high-grade listhesis reduction. So the techniques are there. It's very small, short time to talk about it. But even if you are able to, there are times when you can't get your number 4 inside. That's the time when you have to take the upper. This is going to be the one that has gone back, and this is the one that is slid behind. So this corner needs to be taken out. You need to take out about 2 to 3 millimeters of this corner. You can use a chisel, or you can, and then I have a set of distractors that start at 6 millimeter height but are 2.5 millimeters thick. That's what goes in, and then we gradually use it like a car jack, and they are blunt puka chisels and distracted. The moment you start doing it, you will understand if it's yielding or not. If it is not yielding, you need to dock from the opposite side and knock off that facet. That gives you some yield. If that doesn't happen, then you have to use a 90-degree small number 3 lumbar curette and go under and start scraping so that you release the PLL under surface, and that's how then the whole thing opens up. And so far, we have not had a problem of converting anything to open or leaving a suboptimal reduction inside.
No, but I think it all depends on depends on case to case basis, and depends on how much it is unstable. If it is really unstable, I would always feel that a partial reduction always helps in decompression and getting into the disc. I don't reduce it completely, reduce it partially, and then do a intradiscal work and everything. And I reduce my listhesis on a sizer, not on the cage. Because I do feel once we reduce it completely, the cage size sometimes changes. So I distract it, put my sizer inside and reduce it on the sizer, and then put my cage so that I do size my cage properly.
Absolutely. It's the unstable ones you don't need to worry. It is the stiff ones you need to worry about while reducing, because those are the ones don't come in. Unstable ones usually just correct by a grade or 2 the moment you position them. It is the stiff ones you worry about.
Yeah, surgical strategy depends on case to case. You have to vary.
And Subir, there is one more question in the Q&A.
Yeah, it's open here, but Shubhai was raising his hand.
I was saying that there are 2 methods of distraction. One, you can do an intradiscal distraction, and one is distracting on the screws. Now, when you do an intradiscal distraction in a case that is completely settled down, you can even get your pen field in and turn it around and slowly open it up. Now, what that causes, it causes ligamentotaxis, like you would do in a distal end radius. And that ligamentotaxis will then pull the vertebra on top back enough for then your screws to reduce it. So I would do what essentially Vishal sir said, that we go into the disc space, open it up slowly, sequentially.
Right. So there is one more question by one of the delegates, is that what is our take on percutaneous pedicle screws and a midline decompression and cage rather than using the tube? So would Dr. Vikas Gupta answer that?
I have never attempted that. I always preserve midline.
Okay. I have done in some few cases, it's called single incision mini TLIF, where you actually put a single incision in the line and then put your percutaneous pedicle screws and do all your work from the midline. I have done in few cases. I think Dr. Shankar is here. They have demonstrated it many times. So I think he can comment on that. No, he's not there.
Shankar was here, but right now he's not there.
Yeah. Okay.
I think even Mihir Bapat and some of the people who have actually adopted the techniques later on, they probably do this kind of a mini open, mini decompression, midline decompression and percutaneous screws. So I think let's not have a discussion further, because that's a different ball game altogether. Let's move on to the next.
There's one more question. How many of you use loops for these MIS TLIFs and decompression instead of microscope?
Right. So I think the very quick answer to that would be that everybody probably has used loops at some point, but with more and more number of cases, the degrees of neck flexion that you need to require actually leads to a lot of neck pain. And eventually you tend to move to the microscope. So using loops is very easy when you start, because then you are seeing everything the way you are used to seeing it in an open. But as you go on, you realize that a microscope gives you much better vision.
So I just wanted to know, does everyone compress on the case?
Yeah, first.
So wait.
The first few TLIFs I started off with, I and Devesh Dholkia, we did naked eye.
Yeah.
We have done a 2-level naked eye. Unfortunately, now as 15, 16 years down the line, as we get in reading glasses, it is now difficult to do it naked eye. I would advise a microscope. Loop is kind of very bad for your neck. We tried once and we just, the first case, we tried with a loop, couldn't do it, just took the loop off and finished the TLIF. So when you're young, you can probably see it better. But as you tend to get middle age, it's better to get used to a microscope and save cervical spondylosis.
But I still use loops for my most of the cases. Sometimes microscope is not available and the neurosurgeons are using it. So all I do you get is loops. So I do use loops.
For most of us, loops are now plan B. For plan A is microscope. Shumo, quickly, because now we have to move on to Bala.
Yeah. Does everyone compress on the TLIF cages?
Yeah.
No.
Why not?
I don't.
I don't either. So, Vishal sir, what about you?
I don't need to compress. I put large lordotic cages. The average size we did last year was 14 millimeters. 16 is the tallest and the smallest we've used is 13. So the scope of, once you put in a proper lordotic cage, it falls into place. Then the screws just need to hold. You put pressure on screws, majority of them are going to behave very badly because the bone is not so good.
Okay, let's move on to Bala's talk. There's something else I wanted to talk, but we don't have time. So Bala, can we have the next talk by Bala, please?
Yes. Hi, I'm Dr. G. Balamurali, consultant spine and neurosurgeon from Chennai. So thoracic discs are very rare. Symptomatic thoracic discs are about less than 1%, common levels being T11 and T12, and most of them are calcified. Various techniques have been identified from laminectomy, transpedicular, costotransversectomy, and thoracoscopic approaches. They all have their various complications. Giant thoracic discs are very rare, and they're usually defined as something that's more than 60% canal compromise. Here's a case of a 56-year-old male with a Nuric grade 3, which shows that there is a significant thoracic disc at T8 and T9 level, which is causing significant spinal cord compression. So the surgical technique I'm going to describe is a mini thoracotomy on the side of disc with muscle splitting and probably rib head removal with no instrumentation. The surgical planning involves an MRI scan, a CT scan to look for calcification, X-ray to monitor the level, neuromonitoring. So a 50-year-old patient presents with Nuric grade 2 thoracic disc, which is calcified, causing significant 90 to 93% of spinal cord compromise. And an X-ray is done both of the thoracic level and the lumbar level to count the number of ribs and the vertebral bodies. So the position is a lateral position, as you can see in this picture, and to relieve any pressure on the abdomen. Your skin incision is from the posterior superior edge of the vertebral body to the antero-inferior edge, and the blue dot is where your level of interest is. So you also take an X-ray at the same time with a marker to make sure your skin incision is accurately in the disc. So the first you do is you identify your level of interest, and then you identify the vertebral body through a transthoracic approach. And you create an space by drilling the bone on the vertebral body and the rib head as shown in the red box. And the vertebral head is usually need to be resected unless it's not in your way. And this space is used to deliver the disc, the thoracic disc, the calcified disc into the space, so you're not going directly onto the spinal cord. So here's the position of the patient. You've marked the disc level and you've marked your skin incision. And then once you've come to this, you dissect and go down. The lung is deflated in this level on this side. And initially I used to use a retractor, and now I use a tube. And the tube is used and docked exactly over the space. So once you identified the vessels that are crossing over, you have retracted your major blood vessels, and you identify the disc space. And you can take an X-ray again at this point. And then you do the drilling of the bone, remove the rib head, and you slowly drill the vertebral body on both sides as we had previously seen. And here is a picture where you see the yellow part right in the middle is your disc on either side is the vertebral body, and you're creating a trench and a space, and you're slowly drilling and thinning down the bone onto the dura. And you're leaving the calcified part of the disc to the end. And as you're drilling, you have to make sure that you don't enter into the canal, into the vertebral canal, because your disc is going to be calcified and very adherent to this. So finally, then you drill down over the disc space and you thin down the calcified disc in order for you to start delivering the disc into this space. Some of the problems that you're going to encounter at this stage are, one, there will be a lot of epidural bleeding as you start delivering the disc into the space. Secondly, there's definitely going to be a dural defect, especially if it is a calcified thoracic disc. So you need to be prepared and planned how you're going to close this dura and what are the techniques you're going to identify. Delivering the thoracic disc, the calcified adherent disc to the dura, is going to be a technique by itself. So you have to use a combination of micro techniques where you're going to put a gentle pulling pressure with the hook on one hand. As you can see, my left hand that is blocking the view is a hook that is gradually putting a pressure. Then I use a combination of knife and scissors to gradually deliver the adhesions and remove it. Though it is going to be adherent to the disc, you need to make sure that you're not pulling a traction on the cord. So you will be doing neuromonitoring throughout this procedure at this point. You'll be having your assistant to help you with the bleeding, and you very slowly, gently are going to deliver this thoracic disc into the space where you have created. If you lose neuromonitoring, you need to stop at this point. You need to wait for some time, make sure you keep your pressures up, and then you restart the whole process and gently deliver. Sometimes you may have to leave a small amount of the calcification adherent to it as long as you're able to deliver most of the disc. But ideally, it comes back as one piece. I've never had a problem in trying to deliver it because the entire disc will then come into one piece into that space. So most of the complications can happen at this phase where you have bleeding, you have CSF leak, and at the same time you're trying to deliver and remove the disc. So once you have actually removed the disc, the next thing you're going to do, as you can see here, deliver the disc into the space, and finally it is all completely removed. So here's a similar case of a thoracic disc where you're gently removing, and this is very adherent both to the dura as well as there is a lot of bone formation all around, and we're just using a combination of techniques to gradually pull it. We did lose monitoring very briefly while doing this case because the calcification was so significant and so adherent that it was actually pushing on the cord as well as adherent to the cord itself. We had to use microscope. Use microscope all the time, but here we had to look in more inside in order to release the adhesions. So here's your dural defect. So now you have to start planning how you're going to close the defect. So I use a technique, a sandwich technique with a substance called taco seal. So taco seal actually helps you with closing the dural defect. It has two surfaces, a white surface and a yellow surface. So the yellow surface is the one that is very adherent, and the white surface is non-adherent. So I'm using the yellow surface to face on the outside, while the non-adherent part is sitting on top of the spinal cord. And with this yellow surface, I'm going to sandwich the other part of the yellow surface from another piece of taco seal. So the same can be used for both of them. And once I've done this, and you just very gently ease with a little bit of saline, it gets really adherent. And with the CSF pressure from inside with pulsation, this gets nicely stuck together. Following this, I also use to add more T-seal as well, a tissue glue of any form on top of this, and again allow this to settle down, and again place another layer of taco seal. The reason why this is so important to make sure that you do not have any CSF leak is you can avoid many comorbidities, especially of a wound leakage, or because of the negative pressure in the thoracic space, you can have a pleural effusion and collection. And I'm going to show you how we can manage that as well. So again, controlling bleeding is very important because you have a dead space. There are many advantages And here you can see that post-operatively, you can see how nicely the bone has been removed, the rib head is removed, and the post-operative picture shows an complete removal of the thoracic disc, and the spinal cord has come into it. The advantages being you avoid the risk of standard thoracotomy. It's a small opening, good visualization, no instrumentation, no manipulation on the cord. There are, of course, complications, neurological deficits, dural complications, tension pneumothorax. Here are two other similar cases we have done of a T9-10 calcified disc and a T7, T8. The same patient who came in post-operatively did extremely well after removing the thoracic disc, but 10 days later he developed an acute headache and diplopia, and he had an abducens nerve palsy. So here we have not used the sandwich technique, and we've just used tissue glue with some tissue from around fat graft that we had used. Obviously it didn't work because of the negative thoracic pressure. We had to go back in again, make sure we control the bleeding from surrounding surface, because for the taco seal to work, you need a really nice dry surface initially. So once we were able to achieve this, then taco seal was placed in the same way as we described previously, and then a combination of TSeal and more taco seal. You just wait for it to get really dry, really adherent, and then you get excellent results. So this patient had the same technique used, and within about 4 to 5 days, his sixth nerve palsy gradually got better, and the patient was discharged home with normal vision. So it's very important that the CSF leak is considered seriously, otherwise you can lead into various complications of infection, meningitis, tension, pneumothorax, and so many problems. There's not many series of these giant thoracic discs. However, most of them in this series, in both these series, have been done through anterior approaches, either through a standard thoracotomy or through mini thoracotomy. So this is an excellent procedure to deal with calcified thoracic discs as large as 92%, but CSF problems have to be looked into. Thank you very much for the opportunity.
Excellent presentation, Bala. It was really fantastic presentation. Now,
thank you
do
so
we
much.
have any questions from the panelists? Okay, so I have had the opportunity to do these, but I have done through the classic open thoracotomy approach. Now, the difference perhaps is in the incision, and perhaps you have the multi-retractor option, like we used to have the SIN frame. So in the initial cases, before you started using the tube, you said you did the multiple retractors. So what allowed you to shift, and where do you dock your tubular retractor now if you do them through the tube?
Yeah, I think that's a very important learning curve where you have from being able to do a reasonably big thoracotomy, and you're able to see the major vessels, you're able to retract, you put deep retractors. So once I kind of learned how to do that, and then I wanted to try to use a tube. And once we started having the tube, the first thing I do is I use a marker to mark the disc level. So once I have the disc level and I've done my mini thoracotomy, and the lung is deflated anyway, and you have a nice big cavity and space inside. So the docking, as you said, is very important here, because your landmark here is the two vertebral bodies and your disc space. And you probably will have the rib head as well coming down, and sometimes that can be difficult to dock it. So your docking space would just be exactly at the spot on the disc where you're going to operate anteriorly, posteriorly as much as possible, which is more towards the canal. And that is where you would dock. And you may have to sometimes shave or drill away the rib head in order for your tube to stand there, and you have to secure it very nicely. So it's very simple, because here you're actually not doing anything where you're trying to hold and dilate through muscle layers. Your muscle layers are all on the top. So once you go past your few muscle layers, which you can just do it with your finger, and once you go past in between your rib heads, then it's just an empty space. because you're into the cavity and your lung is deflated, so you're into an empty space. The problem and challenges will be in docking is when your lung does not deflate fully, or if you're going at a much higher level, more than T6 level. So where you still have some lung, where you have to use some, cottonoids and other things to push and wait for the lung to deflate. So you really need a good anesthesia team where they can really help you with deflating the lung. So I think really it is not as difficult to dock the tube, because once you go through the split muscles, you do it. One other thing I've noticed is some patients have developed, by chronic retraction, they have developed neuropathy and neuropraxia because of the nerve underneath the rib. So I've recently, I've done about nearly 7 or 8 similar cases, and the last 2 cases actually did resect a piece of the rib from there, and those patients did not develop the problems, because one of the things that a couple of my patients had is a really severe neuropathy pain that they had persistent, and probably is because of the prolonged retraction. Yeah.
Mm-hmm. Okay. Okay. Yeah. Somebody else?
Yes. Yeah. So when you take down the rib head, do you take down the pedicle also in all cases, or in selected cases?
No, there's no need for you to take down the pedicle at all.
Okay. Because the one CT which you showed now in this case, the opposite side I could see the pedicle, and the same side I couldn't see the pedicle. So basically, does it help taking down the pedicle?
No, it doesn't really help, and because your attention is all going to be more towards the getting the cavity anterior to the disc space. So your pedicles are lateral. So your pedicle doesn't need to do. Maybe the CT cut that I had shown probably was not very clear, because I only showed you one single cut. But if I show you the rest of it, the pedicles are intact.
If you extrapolate it to the open surgeries, typically what has been recommended is that you shave off a little bit of the upper edge of the pedicle of the vertebrae below to give you more space. That was what was being taught traditionally, but depends upon each surgeon.
If I can just elaborate for the beginners. So initially, when I started doing this, when I was training in Nottingham, the way that this was approached is they did a much more bigger vertebrectomy, and did a bigger cavity where you actually removed the vertebra body, and then they instrumented it as well. So you have a big cavity there, then you do all your decompression and everything, and then you instrument it with a single level instrumentation. So by doing the minimally invasive technique, all you do is you just create a space, and especially it's only unilateral, and you're not violating any of the pedicle or the posterior elements. You only need the space to actually pull the disc back inside. None of these cases we've instrumented, but yes, in the beginners you can do a bigger vertebrectomy and you can put instruments.
Bala, what other techniques you would say to basically seal this dural rent other than taco seal sandwich technique?
Yeah, so suture is out of question in this technique. I don't know. I've tried once or twice. It's difficult. So you can use a combination of various dural substitutes, Johnson & Johnson, Integra, and various other kinds of implants are there. Substitutes are there. You can place them on that. Some of them require suturing, some of them don't require suturing. And then after that, you allow it to dry nicely and use as much, probably 2 ml to 4 ml of tissue glue of any kind. So I think that's the only option. And then muscle, fat graft, pack it. And once your lung inflates, then hopefully, that place kind of gets sealed. So I think that's the only other technique that you have. And just fingers crossed it doesn't leak.
So unless you have all these things, you don't advise it to be done in this way.
So you definitely, that there's going to be a dural rent. So you have to be prepared. Whatever is available in your hospital, in your setup, is best for you to use. But just make sure you don't keep any small pieces that enters into the canal, because your dural opening is quite big.
Okay. I think we are running short of time. We are at 2:15. We are only 5 minutes behind. Can we have the next lecture by, thank you, Bala, that was very great. Can we have the next video by Umesh? Umesh Srikanth.
Chairpersons, senior colleagues, and dear friends. At the outset, I would like to thank the Assicon Organizing Committee for giving me this opportunity. And I've been given the topic of to talk on minimally invasive posterior cervical laminoforaminotomy and discectomy. Well, if we consider the options available for treating a cervical disc prolapse, so as we know, anterior cervical discectomy with or without fusion has been there for a long time. It has been the standard of approach. And as we know, it removes the disc completely as well as restricts motion. Ultimately, even if a discectomy is done, there is a end result is a fusion. So basically, it removes the disc as well as removes the motion. Just to circumvent this, an artificial disc was implanted in several cases, which of course removes the entire disc, but it attempts to preserve motion by inserting an artificial disc instead of a fusion device. But ultimately, we know the limitations of artificial disc as well. Posterior laminoforaminotomy, even though it has been there for a very long time and is basically an extension of the concept of a lumbar fragmentectomy or a limited discectomy that we often do in the lumbar region, which doesn't involve inserting any kind of a graft or instrumentation. It preserves the patient's natural disc, removes only the fragment or the disc prolapse that has happened, and relieves the patient of the radiculopathy. At the same time, without implanting any external device and preserving motion as well as preserving the natural disc of the patient. Of course, there are several limitations for this because of the venous bleeding, early facet arthrosis, and higher chance of recurrence in these cases. Well, the typical case for posterior cervical laminoforaminotomy is a laterally located extruded or a protruded disc prolapse causing a unilateral radiculopathy, and such as this case, as is shown in the example. And especially if we observe this patient also has a superior adjacent segment disease in the form of a disc osteophyte complex, which is currently asymptomatic. And in these cases, adding a fusion device from anterior at the level of C6-7 or at the level of a symptomatic case may further worsen the adjacent segment disease. So in these cases, either motion preserving surgery or a disc and a motion preserving surgery, which is always better, can be the right option. Well, the patient is always position prone, ideally on head pins or horseshoe, or a face mask can also be used based on our convenience. The neck is either maintained in a neutral position or slight flexion is advocated. A plaster can be used to pull the shoulder down to visualize the lower level, especially C6-7 or sometimes rarely C7-D1, where this laterally located disc prolapse can also happen. A pressure point should be adequately padded, especially if we are using a horseshoe or a face mask. The eyes have to be particularly looked into. Intraoperative neuromonitoring is not mandatory, but because it's available, we use it for many of our cases. Well, the first step is to mark the skin incision. Usually that is in line with the disc space with a needle, that is before prepping the patient. And we mark the skin incision around 1 to 1.5 centimeter lateral to the midline. So we have to understand that cervical musculature is made up of many layers, and like in the lumbar spine, we cannot just plunge with our initial dilator because it is made up of multiple facial layers, multiple layers of the muscle. It is not very easy. Plus, the cervical spine is much more fragile as compared to the lumbar spine, is not as rigid. So inadvertently plunging a first dilator can significantly cause some kind of a trauma which we don't want. So it's always better to have a blunt dissection in the beginning in order to localize the disc space. So the incision is anyways deepened till the fascia, and the blunt dissection can either be carried out using the dissector that we commonly use. It's a flat Howarth kind of a dissector which we use to separate the muscle fibers, and with a sweeping up and down motion we can go into the desired level, at the same time creating the track that is required. And this up-down motion usually prevents any kind of inadvertent plunging in the interlaminar space. So once this bone is palpated with a dilator or with a blunt dissector, then the first dilator is introduced, and then sequential dissection is carried out. So this sequential dissection again should not be done under any force. It should be very gentle, yet it should be firm enough to dock each subsequent dilator on the bone. We should palpate the bone with each subsequent dilator. K-wire, of course, nowadays I think most of us do not use a K-wire because a lot of complications are associated with by using a K-wire. Once the tube is positioned, of course, it is always checked with a C-arm. Appropriate length of tube is placed over the last dilator. Usually a 16 millimeter or an 18 millimeter tube is sufficient for doing a cervical laminoforaminotomy and discectomy. And this tube is then anchored to an external flex arm assembly, and fixed to the table. So the first step usually is to dissect out the muscle in order to identify the bony landmarks. And the reliable bony landmark is usually the upper lamina, the lower lamina, and more importantly, the angle that is created in the lateral edge between the upper and the lower lamina, which usually marks the medial edge of the facet joint. So once that is done, a little bit of the facet joint that is lateral to this point is also exposed. That is actually shown in the figure that is there. Mediolateral orientation is also checked in this case. Too much lateral orientation of the tube can also result in facet drilling or instability, as well as too much medial orientation can result in a larger amount of laminar resection, which is quite unnecessary in these cases. So this is basically a small video that shows the drilling that is taking place. That is the inferior lamina that is being drilled. Of course, in many of these cases, more dissection is towards the inferior aspect. Once the dissection is done, then carefully the ligamentum flavum is separated from the underlying venous plexus, because if you are not careful, then this can result, as you can see, there is a rich venous plexus underneath. If we don't separate it carefully, then it can result in significant venous bleeding and it can hinder our visualization of the disc. Once that is done, the venous plexus itself can be separated either from medial to lateral or from superior to inferior from above the root. And then these venous plexus are coagulated in a circumferential area in order to expose the lateral margin of the dura, as we are seeing there, and the lower margin of the nerve root. So most of these cervical disc prolapses are located in the axilla, or they are directly under the nerve root, as we are going to show it later. So in either of these cases, so once the disc fragment is identified, the lateral margin of the dura and the lower border of the nerve is identified. So either the extruded fragment is removed or a small annulotomy is made in order to get access to the disc fragment, as we are seeing there. So this is one disc fragment, but of course this was a very large disc prolapse. So as you can see, gentle dissection can be done using a right angle probe without causing any significant medial retraction of the dura. And then these fragments, or one or multiple fragments, can be delivered. So usually, invariably, once we remove these fragments, there will be associated some venous bleeding because of decompression, or because the venous plexus was usually compressed due to the presence of the disc prolapse. So this can be easily coagulated, or some hemostatic agents can be used in order to achieve hemostasis. So once that is done, the area is again probed for any loose fragments, thorough wash is given, and the nerve root can actually be palpated in order to see whether it is free or lax. So this is an ideal treatment approach. The lateral foraminotomy is an ideal treatment approach for cases which are, where there is a very small disc prolapse and it has failed conservative treatment. So in these cases, as we are going to see there, this is from a superior orientation. We are standing on the head end of the patient and we are operating. So I'll just fast forward this video for lack of time. So as you can see, this is under the nerve root. There is no disc fragment that is visualized in the axilla. So and then that can be removed, and then the nerve root and the dura can be easily identified. Well, the beauty of this approach is, as we are removing the tube, we can actually see all the muscle layers that are falling back into place. So as we can see, there are multiple muscle layers actually in a crisscross fashion that we have divided with our elevator or the dissector as we are going in, can be visualized coming back into place. So that is the track that we have created, and that can be visualized clearly, and hemostasis also can be achieved at the same time. So that is how the incision is going to look. So this was a 2-level case. So there are several problems that we can anticipate. I'll be quite quick because of, I'm probably running out of time. So those that are general, that is venous bleeding, as I have already told, can be controlled by, careful drilling as well as preserving venous planes. Of course, the idea when there is no fragment that is detected, we should always check with a C-arm to see the position of the retractor and check the level. And of course, whenever there is no fragment, then a good foraminotomy should be done in these cases in order to get significant clinical benefit. When specific to MIS, of course, K-wire we don't use it nowadays. Again, dilatation, tube lateralization, I've already covered it. Positioning the tube has to be very accurate. Medial and lateral orientation has to be taken care so that the excessive lateral drilling or excessive medial orientation causing more unnecessary exposure of the dural sac or the thecal sac can be avoided in these cases. We know that several studies exist which show the superiority of minimally invasive cervical laminoforaminotomy over open cervical laminoforaminotomy, and this is one of the studies which was published quite some time back. Our experience now is slightly more than 50 cases, and we have also published our initial cases comparison with our open group retrospective study, of course, which showed significant differences in blood loss, IV analgesic usage, as well as post-op hospital stays. But more importantly, the VAS for the neck pain at 6 months post-op was different in the MIS group as compared to the open group. So just to summarize, minimally invasive posterior cervical laminoforaminotomy is safe and effective. Case selection is very important. So that dilatation technique is slightly different, and it should be more cautious than what we use in a lumbar region. And as we know, it results in significant clinical benefits like decreased incidence of postoperative axial neck pain, blood loss, postoperative analgesic requirement, hospital stay, which entails a patient to go for early return to work. Thank you.
So that was hello.
Subir, we can hear you, Subir.
Yeah. So thank you, Umesh. That was a very elaborate demonstration of a posterior cervical laminoforaminotomy with discectomy. Now, I have a quick question before we come to the end of the session. Is that can you do decompression or drilling of the osteophytes over the posterior edge using the MIS tube, or would you just do a laminoforaminotomy for a posterior osteophyte and leave it like that?
Well, in the presence of a disc osteophyte complex in the foramen, posterior laminoforaminotomy alone should suffice, unless there is a significant anterior compression, in which case I would definitely recommend an anterior cervical approach rather than a posterior, because drilling the osteophytes, though it can be done, it can be accessed. Drilling the osteophytes which are close to the nerve root there, because nerve root retraction, we cannot do it as we do it in the lumbar region. So it is slightly riskier.
Okay. And somebody has asked whether if you want to do just laminoforaminotomy and not do a discectomy,
I would,
okay,
in the presence of an acute disc, obviously just to do a laminoforaminotomy and not remove the disc is I don't think it's fair enough. In the presence of an acute extruded disc, of course, along with the laminoforaminotomy, we can remove the disc, and it is not difficult at all. But of course, if there is no acute disc fragment and we are just treating a foraminal stenosis or something, or if we find that the disc is hard and it's very risky to remove that, in those cases, probably we can just do a laminoforaminotomy and create a decompression there and come back.
Okay. Guru.
No. I wanted to ask the same thing which was there in the Q&A. You just asked it. Yeah.
Okay. So I think we are coming to the end of the session. We are bang on time. We were given 2 hours. We are finishing 2 hours. Yes.
So before we close, we have a video from Medtronic on basically robotic spine surgery, a short video. So we'll play that and then we'll end this session.
Okay.
Yeah.
Expertise, experience, preparing you for this moment. This is where it all comes together. Your skill, your vision, their future. Mazorax Stealth Edition Robotic Guidance, combining the technology and experience of Mazor Robotics and stealth navigation. Anticipate issues before they arise. Optimize your construct design. Planned, predictable, confident in every moment. Precise. This is the next level of surgical technology. Visualize your progress as you work and adapt to meet your surgical goals. Mazorex Stealth Edition, extending the reach of your expertise.
The OLIF 2.5 procedure is a muscle-sparing approach through an oblique corridor to access multiple levels of the lower lumbar spine. When considering an oblique approach, we have to consider the anatomy, specifically the peritoneum, the psoas muscle, the sympathetic chain, the ureter and kidney, the lumbar plexus, the vasculature in the lumbar region, and the anterior longitudinal ligament, or ALL. Let's start with the peritoneum, a thin membrane lining the abdominal cavity containing the intestines. Anatomical concerns with the peritoneum are tearing the membrane or perforating the bowel or intra-abdominal contents. In an OLIF 2.5 procedure, the patient is positioned laterally and the peritoneal contents fall anteriorly due to gravity. The finger or blunt instrument enters the retroperitoneal space from a more anterior position, pointed posteriorly to skive off the top of the peritoneum. The peritoneal content can now be swept anteriorly, creating the oblique corridor. The finger or blunt instrument protects the peritoneum as the first probe is inserted. The psoas muscle in the lumbar spine contributes to hip joint flexion and rotation. In traditional trans-psoas approaches, dilation and retractor placement through this muscle can lead to muscle trauma. Stretching of muscle by jackknifing the patient and surgical table and dilating through muscle can result in post-op neural complications. The OLIF 2.5 procedure uses a trajectory outside or within the anterior portion of the psoas, reducing trauma to the muscle. This trajectory is also away from the posterior nerves of the psoas muscle. The lumbar nervus plexus crosses the midpoint of the L4-5 disc space. Most often seen traversing midpoint of disc are the femoral nerve and the obturator nerve. Anatomical concerns include injury to these nerves, particularly via compression and stretch during opening of a trans-psoas retractor, which can lead to post-op neural complications. OLIF 2.5 has a trajectory away from posterior nerves, including the femoral nerve. The genitofemoral nerve exits the psoas muscle at approximately L2 disc space and may be visualized during the OLIF 2.5 procedure. If visualized, it can be mobilized temporarily to allow for entry into the disc space. Kidneys and ureters are part of the urinary system that delivers urine to the bladder. A concern for retroperitoneal procedures is location of the kidneys and ureter and potential injury. As part of pre-op planning, surgeons should evaluate for abnormally low kidneys at L2 disc space or kidney transplants. The ureter is usually attached to the peritoneum and will move anteriorly with peritoneal contents as they are swept forward. Retractors may be used to directly visualize and protect the ureter. The sympathetic chain consists of ganglia on both sides of the spine and may be injured when approaching obliquely. If visualized, the sympathetic chain may be moved anteriorly using a blunt dilator or Kittner to move soft tissue from the anterior psoas to the anterior longitudinal ligament. A small percentage of patients may experience transient lower extremity symptoms, such as leg warmness if the chain is injured. Lumbar region vasculature primarily consists of the great vessels, the aorta, and vena cava, and multiple segmental vessels and tributaries. Anatomical concerns are irregular vasculature, location of the iliolumbar vein, high bifurcation, and transitional anatomy. In the OLIF 2.5 procedure, look at pre-op axial MRIs to evaluate for irregular vasculature. Positioning patient laterally, left side up, increases the size of the corridor between the psoas and aorta as the great vessels move to the right. The preferred starting position of the probe on the disc space is anterior to the psoas and away from the major vessels. An OLIF 2.5 approach works away from peritoneum and anterior vascular structures. The iliolumbar vein may be observed in L4-5 disc space of patients with transitional anatomy. For these patients, direct visualization is recommended to identify iliolumbar vein location. The anterior longitudinal ligament is attached to each vertebral body inferiorly and superiorly at the end plates level. OLIF 2.5 allows direct visualization of the ALL, and surgeon may leave ligament intact or release the ALL for greater lordosis. The OLIF 2.5 procedure enables an approach away from the posterior nerves of the psoas muscle and works away from the peritoneum and anterior vascular structures. Direct visualization is recommended to ensure specific anatomical structures, such as the ureter and sympathetic chain, are identified and mobilized away from this approach.
So as we conclude, thank you very much all the panelists as well as all the speakers and the questions that were asked by the delegates. I hope it was quite fruitful for everybody. And I think we're taking up more time from the next session. Should we end, Ankur? Can we end?
Yeah.
Yeah.
Yes, I think we can end, and
Yes.
I think everybody needs.
Thank you very much all the panelists as well as all the speakers and the questions that were asked by the delegates. I hope it was quite fruitful for everybody. And I think we're taking up more time from the next session.
Ankur, what's happening?
Should we end, Ankur? Can we end?
Yes.
It's recording.
Okay.
Yes.
I think there is some lag.
No, we can end now. So we take a quick break, and I think everybody must be feeling hungry. So we can then join back sharp at 3 o'clock for the next session.
Yeah.
Bye, guys.
Okay. Bye, guys. We had a great time.
Bye.
Hi Varun. How are you?
Good afternoon, sir.
How are you?
How are you?
Good. Hi Shailesh.
Is the transmission on hold, sir, or something? Because
I think the session is at 3 o'clock.
Okay.
So it's just about 5 minutes more maybe.
Hi Ajoy. Hi, sir. Hello. Shailesh here. Yeah. Hi.
Hi.
We will be starting at 3.
Yes.
Okay.
So what
I'll be stopping the video for a while. That's all right.
How will you do it?
From my end, I'll stop the video. Let the session start. I'll be back on.
Okay. Acha, video. Okay.
Yeah.
Okay, fine.
Right.
Sure. Yeah, carry on.
Good afternoon, everybody. Ketan sir, hello. Good afternoon.
Hi, good afternoon, Ankur. How are you?
Shailesh भाई शक्ल तो दिखा दो.
हाँ अभी दिखा रहा हूँ रुक. Hi.
क्या हाल है?
मैं देख रहा था.
All set.
Some problem. I cannot do this background, Ankur. I tried, but there is some issue.
कुछ सॉफ्टवेयर का इशू होगा then. So what is happening is थोड़ा older version जरा भी है ना, then it doesn't catch up.
We are not like advanced from Delhi, na. We are older version from Pune. Retiring city.
Oh, come on, man. You are OrthoTV star.
Good.
अभी Star TV में कब आ रहे हो ये बताओ.
OrthoTV has joined. GeoTV has taken over. You know that?
I heard.
Yeah. So it's
what's GOT? What's that?
GeoTV. Geo 24 hours. Geo. This Reliance.
Acha.
They have joined hands. Yeah. Now there is a collaboration between OrthoTV and GeoTV.
So that will be on the cable network also then.
That will be on. It is online. They are doing all 24 hours for anyone can watch it now.
So Ketan sir को हमने वो नहीं भेजा है actually virtual. Ketan sir, do you need the virtual background?
अभी जाने दो ना. अभी late यार.
Okay, fine. Actually, I was putting from my mobile. मेरे मोबाइल में आपका नंबर फीड नहीं रहा तो actually
अच्छा. Okay, no problem.
So the idea is, I think initially Dr. Ajoy had said that we will allow people to share their screen and do on their own. But what we realized in the earlier sessions in the morning is when the screen was being shared by the speakers, there was a lot of glitch and time was getting wasted. And वो आ रहा है नहीं आ रहा है दिख रहा है नहीं दिख रहा है हो रहा था. Again, then turn back to plan A that we will be running all the presentations from here. And take question answers subsequently.
Yeah, okay. Right.
So they will run everything. And Ketan sir and Shailesh, as we start, you take over directly.
Yeah, sure.
So what you mean is we don't need to pause in the middle. First let the entire video run.
Yeah. So what was happening is when we were sharing and everything, then there was a lot of glitch. If you want us to pause in between or you want to share and specifically say something, then it's a different thing. But I think everybody has done a very good voiceover.
Yeah.
So ऐसा जरूरत लगी नहीं.
So we can speak in the middle, na? Or
so if you speak in the middle, it will need to be paused. So that means we will need to pause here.
No, what I mean is that there may be some gap in the audio because next step aane mein. So in that, can we fill over or is it not required?
So if someone is along with that, someone is monitoring, some fellow or anyone is there.
No. So this is in their AV secretariat. They're running it from there.
Okay.
Everybody is sitting at their place.
So if we tell them कि थोड़ा सा pause, please pause ऐसा तो will they pause it?
हाँ, शैलेंद्र जी एक बार बात सुनेंगे?
Yes sir.
शैलेंद्र जी डॉक्टर शैलेश बोल रहे हैं कि वो बीच में ऐसा pause के लिए बोलेंगे कि can you please just pause? तो आपको सुनते रहना पड़ेगा, pause करना पड़ेगा. तो आप कर लोगे?
Sure.
क्या तो किसी को कोई like ये videos है उसमें कुछ point बताना है वो time पे तो that will be useful.
Done sir. हो जाएगा.
हाँ तो मेरा जो है
presentation आप ही को बोले ना कि आप करोगे.
वो सर बीच में बोल देंगे प्लीज पॉज द वीडियो तो हम पॉज कर देंगे.
ठीक है.
कि जैसे जो वीडियो तो चल रहा होगा ना अपना बैकग्राउंड में तो हम लोग भी लाइव होंगे क्या द स्पीकर सो दैट आई कैन स्पीक
ओनली द स्पीकर यू विल बी लाइव You can speak, but what will happen is video is speaking, and if you speak, then it will be very, very.
That I will take care.
Buffering.
So you can't speak at that time, or you can ask him to pause.
Okay. You don't want an overlap, na? That I understand. Yeah.
Samir sir is also here.
Sir, we
Hi,
are live
Samir.
in 3 minutes.
Hi, Samir.
Guys.
Hello, sir.
Hello.
बोलिए सर.
लंच हो गया समीर सर का लंच हो गया अभी लेट.
अभी लंच हो गया, अभी कॉफी.
Good.
So the delegate questions are coming in Q&A.
Yeah, they are coming in the Q&A. Yeah.
So we have to make it more interactive.
Yeah.
More discussion oriented.
True, sure.
So we'll ask simple questions, so that a lot of people who are new and junior, they will understand. So whichever question comes in faculty's mind, they can ask to the relevant speaker or anything.
Yeah, definitely.
We have seniors, experts, Dr. Dhanvi, Dr. Badani.
The videos will be played, so we have no stress, right?
No stress.
They will be played from the back.
Only Q&A. Yeah. Okay. My video is actually much shorter than the time allotted, so there'll be more questions, I guess. Yeah, but if other people are running over time, then that's good.
No, sir, none of them are running over time. Except Shailesh has a 30-minute video.
No. अरे मेरा 19 minute का है, जरा देखो.
I know. Then you cut short.
But Shailesh का topic बहुत बड़ा है.
It is covering so many
Tips
things.
and tricks and complications, so it's a lot.
अरे मेरा तो टॉपिक है पूरा ऑस्टियोपोरोटिक फ्रैक्चर्स का. मैं तो 2 दिन बात कर सकता था.
No, I did it again, and it is 18-19 minutes now. So I covered all the tips.
What is your allotted time?
20 minutes.
20 minutes.
That's good, no? Sir, we are live in 1 minute.
Yeah.
20 including discussion.
15 minutes and 5 minutes of discussion.
So no discussion, only 1 minute.
मैंने सुना रुपिंदर कुछ वैक्सीन के बारे में बोल रहे थे.
He got some febrile effects and feeling a little bit of vertigo also. Still.
No, actually, when I log into Hall A on the website, I hear Dr. Rupinder and Dr. Nanda, and I think you were there discussing on a vaccine.
So
on the
actually
website.
They had not stopped the live thing.
Okay. That was what I was wondering.
So I see Shailendra ji, मैं आपको यही बोल रहा था. You are not stopping in time. So I told
think
Shailendra
today we will finish by 5:15 max.
Yeah, the last session, so we have little leeway.
Yeah.
Anyway, guys, I'm quite okay. I got my vaccine yesterday.
Even I got it yesterday.
Yeah. So far, so good.
Sir. So it was okay.
So today I had some myalgia and headaches and.
We have not yet got the vaccine in Pune,
I couldn't make out because every Sunday I get myalgia because I feel lazy. So I don't know whether this is Sunday myalgia or vaccine myalgia.
Shailendra ji, how much time
you are live now?
Yeah.
Like.
Are we live? Are we live now?
I think 30 seconds more.
Okay.
Shailendra ji, are we live now?
Yes, sir. We are live in 30 seconds.
Yeah, okay. Live now? Hi, good afternoon, everybody. After a very interesting sessions in the morning, we now move over to another very interesting session, and this session is basically about osteoporosis. So osteoporosis is very highly prevalent amongst different age groups and a wide variety of age ranges, and as a consequence, we face the problems of osteoporotic fractures very commonly. The prevalence of osteoporotic fractures is supposed to be somewhere around 20-25%. So it's a very interesting and important subject which we all spine surgeons come across in the treatment of our patients. We have a very expert and senior faculty as well. Dr. Sameer Dalvi, Dr. Arvind Bhave, Dr. Sailesh Hadgaonkar, Dr. Ankur Nanda is Dr. Varun Agarwal and myself. So we'll be discussing, and we want the session to be very interactive. We invite all the participation from the delegates. So without wasting much time, I would like to start off first with the presentation by Dr. Sameer Dalvi on rationale of the management of osteoporotic fractures. Can we start the presentation, please?
Thank you. I think it's a recorded presentation. There we go. On osteoporotic fractures, and I'm just going to talk about the very basics of how to decide what it is that we are going to do. So this is a very, very common X-ray which you are seeing in the OPD nowadays, and the incidence is really going up. And these patients present with pain, difficulty in movements and position change, local tenderness, and sometimes with deformity. So there are basically two challenges. One, of course, you have to manage the symptoms. They're very distressing at this age. And the other thing is diagnosing and correcting the underlying cause. Clinically, it's very important to look for history suggestive of underlying pathology. You look at the pattern of the pain. Do they have night pain? Do they have mechanical pain? Where is the tenderness? And of course, a detailed neurologic evaluation. The basic checklist includes an ESR, because an ESR is a very, very nice test to see if there's something wrong. If it's sky high, it may be infection, it may be myeloma. We look at the sort of metabolic parameters, vitamin D, parathormone, etc. We look at the proteins to look for myeloma, and sometimes tumor markers. A bone density test may help later on, and in some cases, MRIs and bone scan, but that will come later on. The biggest challenge here is to not miss a pathology, such as an infection, a myeloma, or a metastasis, especially in this elderly age group. And you may even require a biopsy in some cases. Of course, a benign osteoporotic fracture is still the commonest cause of collapsed vertebrae, and X-ray, MRI, and CT together can give this diagnosis. So osteoporosis is really one of the biggest pandemics right now. 200 million individuals are affected depending on the definition. And 1 in 3 women over the age of 50 have an osteoporotic fracture in their lifetime, which is amazing, and 1 in 5 men as well. And there are 15 lakh fractures annually, of which 700,000 are vertebrae. And osteoporotic fractures in women, the annual incidence shadows even heart attack, stroke, and breast cancer. So osteoporosis is a structural deterioration of the bone tissue leading to fragility, but a better definition by the WHO is when the BMD T-score is more or less than minus 2.5. So this is a normal trabecular, and this is the osteoporotic bone. What happens is from 30 to 55 to 70, it becomes thinner and the trabeculae become sparse, as you can see. And that is osteoporosis. How do you manage these? Firstly, rest. You need to give rest only for a few days. Don't put them on 4 weeks, 6 weeks, 8 weeks of bed rest, only till they are painless. Pain medication, whatever is required, whatever is safe, local applications. Bracing, bit controversial, but in the acute phase, it does help. And we give a talus or an anterior spinal hyperextension. And then when the pain becomes less, start on physical therapy. Some other things are calcitonin, which I'll talk about, and management of the osteoporosis. Calcitonin is given as a nasal spray, and in addition to improving the bone density, also gives rise to pain relief. In the long run, weight-bearing exercises, nutrition, modification of risk factors, and pharmacological agents. And pharmacological agents will be covered by Dr. Badani, but there are various sort of SERMs or bisphosphonates, calcitonin, now denosumab, and teriparatide. Now, what happens? A large proportion of these fractures become painless over a period of time, ranging from 3 to 12 weeks. And we always treated these conservatively. But if the pain persists, we then have a procedure known as a vertebroplasty. How do you select these patients? These are patients who have significant pain, which interferes with their day-to-day life. And they should have had 4 to 6 weeks of conservative treatment. And you have to make sure that the source of pain is the osteoporotic fracture and not non-specific pain or neck pain or something else, or even stenotic pain. There has to be selection of the level is very important. We look at the tenderness on pushing. We look at the X-ray findings of a progressive collapse, a vacuum cleft, fluid sign, or instability on dynamic X-rays. And on the MRI, you will see edema or a fluid cleft. And that's what you see. You see edema. So that's how you can time these fractures. And a stir image is an excellent one to do. We don't do bone scans, but if necessary, it can be done. What about the contraindications? The biggest contraindication is absence of indication. I mean, if just don't do a vertebroplasty because you see an X-ray with a fracture. There has to be a whole gamut of indications for you to get your result. Infection, of course, bleeding disorders. If there is a retropulse posterior wall or a cortex which is not intact, you will land up with problems and you cannot do these. So this is what a vertebroplasty looks like, but there's a detailed lecture later on. And then there's kyphoplasty, on which there's a detailed lecture. And there will be a debate as to which is better, which maybe we will take up in the discussions. Now, the complications for an osteoporotic fracture in a vertebroplasty is very low. But in a metastasis and myeloma, it is slightly higher. And you can have complications such as cement leak, bleeding, anaphylactic reactions, and thermal necrosis. So the early one which you are worried about actually is a cement leak. And that cement leak may go to the lungs and lead to fatal embolism, or it may leak out and just be an X-ray finding, or may leak into the canal and give rise to neurological deficit. In the long run, we have seen infections, but the biggest problem is fractures adjacent to and around the cement in the same vertebrae causing problems. So 5 to 15% cases actually have some amount of cement leaks, but symptomatic leaks are luckily not very high. It's 0.1% in osteoporotic fractures. Adjacent level fractures, because this rock solid cement acts like a pile driver into the rest of the bone. And you can also have fractures at other levels and fracture of the same vertebra around, which can lead to very, very difficult management. The controversy was created by 2 randomized trials published in the NEJM in 2009, where they did a blinded prospective comparison of vertebroplasty with a sham procedure, and they found no difference in the outcome. Now, we can talk a whole day on this, whether they were right or whether they were wrong, but they certainly changed the way we did things. And in my own practice, vertebroplasty has gone down to less than 1/10 of what I used to do earlier. Some patients, of course, also need surgery. So if you look at something like this, where there's a retropulse fragment, patients have dynamic cord compression and they can cause delayed neurological deficit. So what happens is that they have back pain from 6 months to 2 years, previous history, may have a history of fall, but they start getting weakness in the legs and bladder involvement. This pain is a transitional pain, which is aggravated by change in posture from sitting to supine, etc., and relieved by complete rest. And if you look at the neurology, or if you look at the MRI, you either see a retropulse fragment, but sometimes you don't see anything. And I'll explain why. It's because they have instability. So this patient may have a normal MRI, but if you do a sitting X-ray, has extreme instability in spite of an osteoporotic fracture. So the problem is not just cord compression, it is also extreme instability. And therefore the surgery has to have decompression as well as stabilization. So something like this would be treated with decompression and stabilization. And that's another one where you can see the white Kummal phenomenon. The whole vertebra has disappeared and there is very little left. And these patients cannot be treated by anything except surgery for stabilization and decompression. And I like to use this sublaminar wire, which works much better in the osteoporotic bone. And they do pretty well. There's another group of patients who have history of fracture and they have severe back pain. They may or may not have early neurological involvement, but they have instability and they have large fluid clefts. Now, such patients we used to treat with vertebroplasty in the past, but we have found that putting large amount of cements into the vertebrae causes more problems in the long run. And therefore, they also have instability and they have a risk of neurology. For these patients, cement augmentation is not enough and they also need to be fixed. But will they tolerate these huge open surgeries? So what I am doing for these now is a minimally invasive procedure where I'm putting in this thing along with the vertebroplasty percutaneous. And what we do is we put in the percutaneous screws on one side and the rod as well. And having put the rod, we then inject cement into the cleft, which is there, because that will act as an anterior column support, and then put the other rod. So this is also a very useful procedure for osteoporotic fractures. So in conclusion, osteoporotic fractures are increasingly common among the elderly. Even your general orthopedic surgeon or a spine surgeon is going to see many of these coming in your OPD. They're almost flooded. Aggressive management of the osteoporosis is the most essential. So I would say any patient who comes to you after the age of 50, please look at their bone densities, look at the metabolic parameters and treat them medically. Many newer medical resources are available now to improve bone density, learn about them, use them, or get your medical colleagues involved, because we have treatment to work. Most fractures improve with conservative measures. This is very important. Don't jump and do a vertebroplasty just because you can do it. The American Academy of Orthopaedic Surgeons has issued a warning against vertebroplasty in acute osteoporotic fractures. But vertebroplasty is useful in persistent pain, and in such an instance, you may still use it, knowing very well that it can have long-term implications. And I've already explained to you that some patients do need surgery. So with that, I thank you, and we will have a lot more discussions later on. Thank you.
Thank you, Samir, for a very nice and concise and very to the point presentation and a good carry home message. Let's have some questions. There are none in the chat box. So, Samir, you were mentioning about the use of vertebroplasty in the acute fractures. You know, there's a lot of trend among some people to do it in the acute stage. What is your take on that? You know, it is what is the present status, when to do it, and what are the hazards that you can have if you do an acute phase?
So, and doing it in an acute fracture is no longer a controversy or a debate. Like I said, the American Academy of Orthopaedic Surgeons has issued a guideline against doing it. And if anyone in the US does it, they stand the risk of being sued immediately because they're going against guidelines. The problems with doing it in the acute phase are many. The biggest one is, like I said, the first contraindication to vertebroplasty is absence of indication. So there is no indication to do it because we have no, and those of us who have worked in the era before vertebroplasty have seen that most of them actually become painless. So this is a situation which is going to become painless, and you are unnecessarily subjecting the patient to a procedure. The second and important thing is that patients with acute fractures have got many microfractures and clefts which lead outwards, which cause an increased risk of cement leak. What happens is these same patients, if you operate them after 3 or 6 weeks, if you do a vertebroplasty, these other things would have sealed and you can fill the cement inside the vertebra. But in the acute phase, these cracks will lead to the exterior, leading to a leak. And last but not the least, the pain relief after an acute is not as good as after a chronic. The reason is that if you do it on day 1, the pain is not coming only from the vertebra. The pain is coming from the soft tissues, ligaments, and there are a lot of other elements which are causing pain. So your percentage of pain relief is really not that good. So in short, you're doing an unnecessary and risky procedure with a low result. And in orthopedics and in medicine, such things should be condemned.
Yeah. Now, one more question I wanted to ask, that many times in the MRI, you were emphasizing on the presence of the cleft, you know, the bright T2 image thing. Many times there is a cleft, but the image is not bright, you know, it is hypo intense. So you found any difference between the two, and is it that the non-bright one is not to be done vertebroplasty or anything like that?
No, in fact, it's quite the other way around. The one who have these big clefts, big fluid clefts, in the past, we used to think that these are the ideal to do vertebroplasty. Certainly, they're the easiest to do because once you get the cleft, the cement just flows into it. Yeah. But these are the ones with the worst results because you get a blob of cement over there instead of the cleft, and the rest of the vertebra fractures. Right. The good results are the one where there is marrow edema. You're just pushing 2 cc of cement. You fill in a few of the fracture lines, or they have one fracture line just below the end plate. And then they have this pain relief because of local heat and local sterilization and not too much cement. These are the ones who do well in the short run and in the long run. Right. So those are the ones which are iso intense. So those ones would do better. The ones with the large clefts nowadays, I'm hesitant to do vertebroplasty. I'd rather operate them if they have instability.
Very large, even very large defect. Yeah.
Yes. The clefts.
Yeah. So if you see a patient on day 1, you obviously, as you mentioned, the conservative treatment is the ideal treatment. At what point in your follow-up would you consider that, you know, now this patient is good for vertebroplasty? What is your waiting threshold?
No, I mean, today, if you ask me, the very earliest with a gun held to my head would be 3 weeks. But if you give me without the gun held to my head, 6 weeks. And so if after 6 weeks they continue to be painful, one would think of them. But there are so few of those now. True. Now that I've been stricter about them, and many of them get sort of better. They're very, like I said, less than a tenth I do now of vertebroplasties of what I used to do in the past.
That's interesting. So there are no questions in the chat box. Any other panelist would like to put up a question?
Yeah, I would like to ask. Hello, Dr. Dalvi. It was an excellent presentation. Yeah. Hi. I just want what you mentioned. I completely follow 4 to 6 weeks minimum, whatever, because we see patients. Some of them are still doing very early vertebroplasty. But what is your upper limit for up to how long you will do the vertebroplasty?
Oh, you mean the latest?
Late, yeah.
Yeah. I think I have done it 6 months as well, and they with a good result.
Okay.
Yeah, provided the cleft is not too large.
Okay. 6 months.
But honestly, these patients are not remaining painless. The ones who are painful are the ones with clefts and instability. If you do their sitting and supine X-rays, or you just look at their MRI and you just send them to the OPD only for a standing X-ray, they will go into a collapse. And those patients, I do the procedure which I showed last. Actually, because of time, I rushed through the thing. I don't know whether my last procedure was very clear, but for them, I do a percutaneous fixation above or below and put cement. So I do a sort of a properly balanced, back and front kind of reconstruction, but minimally invasive. Okay. And these patients, that's what I do now, because if you do only vertebroplasty, I fear that they may fail. So unless the patient is high medical risk, like those who are high medical risk, I would do a vertebroplasty and tell them that there is a chance that this may fail. But those who are not high medical risk will tolerate a 1 hour surgery. I prefer to do this percutaneous surgery.
Yeah, we talk about that cement leakage backwards into the canal. Anyone has any experience or seen patients of this type where the cement is backed out into the canal and caused any neurological deterioration? So you have to revise it and do some surgical open procedure?
So I have never seen one of my own, but of course I've heard stories of friends and colleagues who have got it. I think if one is very, very careful about how you do it, and there are many tips and tricks, and I'm sure we have lots of lectures coming up. Yeah. But if we use the tips and tricks, nothing happens. And you have to make sure that your needle is, firstly, you need to make sure on a CT that your posterior cortex is intact. I think it starts with that. Your needle placement has to be in the anterior third. You have to put the cement when it is not extremely liquid. So that is a fine art, to put the cement at a time when it is not liquid to leak and not too solid to not go, right? And you put it, and you just put it a bit by bit at a time. I actually never push it with a syringe. With the syringe, I only fill the needle and then I push it with the plunger. And you always keep the C-arm on. If the C-arm isn't working or there is any problem in visualization, I abandon the procedure. Let me make this very clear. I would abandon a procedure where I'm not seeing it properly. But I will not go ahead and do the procedure and risk the cement. And I don't put excess cement. I just put cement. I don't go for joy of putting too much. No. 1, 2 cc, 3 cc, that cleft is filled. That's the end of the story. Perfect. Maybe withdraw it a bit, push a few more drops, and then get out.
What is your experience of someone who does it? Even there is a retropulsion. I have seen quite a few. I am not that much daring. I don't have that much daring, but I have seen. What is your experience? I personally feel it's not good, but what is your take on it?
No, my problem with a patient who has got a retropulsion is that even though he's neurologically intact at this point, if you fill cement and if it collapses any further, then you are getting a cord compression with cement and bone. Yeah. Now, such a patient, if you have to do a revision, you're going to have to do an anterior revision for him. Yeah. Whereas the only bone you can just do from the back, you can do a transpedicular decompression. So any patient who has a cement block which is causing cord compression becomes a technical challenge to operate.
So I think it is a very clear message from Dr. Dalvi where we should not put the cement. That's important. And for how long? 4 to 6 weeks is a very good time to consider. If the patient is still symptomatic, up to the 6 months to up to 9 months also, we can consider doing vertebroplasty. That's the message from Dr. Dalvi. What is your take on it, Dr. Badani, sir?
Yeah, I completely agree with Sameer. The primary treatment is, of course, conservative. And I also have a very high threshold for doing vertebroplasties, because putting a natural healing, bone-to-bone healing, is definitely going to give a better result than, you have to do it means if you're forced to do a vertebroplasty, it is fine, but you have to give best chance to nature to heal the fracture, and as he said, emphasis is on the medical management, allowing the bone to heal up. So by doing these measures, I think the need for vertebroplasty is quite low, as Dr. Sameer said.
Sir, I have a question. Is there an upper limit to the time period in which you advise vertebroplasty or pathoplasty? That beyond so many months I will not do it, and what is the procedure in that case which you advise?
So I think in the literature, please answer.
No problem. So basically, I feel that if you can at any point of time, maybe 6 months, 1 year, if you define that the cleft is the cause of the pain, and you don't have any other contraindications to not doing the vertebroplasty, it is fair. I think I have done up to 9 months also, 9 months post fracture. So yeah, upper limit means if you wait too long, then there might be secondary effects of instability and all those things. So the longer you wait, you need to evaluate more in terms of instability as the cause of pain rather than just the painful non-union. So yeah, I have done up to 9 months, but then I would be very careful to check for instabilities.
Okay.
So I think we need to move on to the next talk. And we can keep on having similar questions in the intervening time period. Next talk is on the technique of vertebroplasty. It's a video lecture by Dr. Nikhil Arbati. Can we have that presentation, please?
Hello, everybody. I'm Dr. Nikhil Arbati from Mumbai, and I'm thankful to the Assicon committee for giving me an opportunity to speak today. Today's topic is about percutaneous vertebroplasty. So what does percutaneous vertebroplasty mean? It's basically the injection of a PMMA cement into an osteoporotic fractured vertebra, which is not showing any signs of healing, even after a period of conservative trial, leading to pain and affection in active daily life. So what are the benefits of doing vertebroplasty? Apart from the fact that it gives an adequate pain relief, it helps in early mobilization of patients who have this osteoporotic fracture. Majority of these patients are geriatric patients, so these require early mobilization. Thus, it prevents in the comorbidities worsening directly. Also, it prevents, if it's a junction level fracture, it prevents the collapse from worsening. As in this case, if the patient had been treated adequately before, the collapse would have been prevented from worsening. There are certain indications of doing a vertebroplasty. First of all, our osteoporotic fracture, which has got a conservative trial of 3 to 4 weeks and is not showing any signs of having a pain relief. Patients who have comorbidities and are totally non-ambulatory because of the pain, they need to consider vertebroplasty. If an MRI picture shows a Kamal sign, that is a non-avascular necrosis or non-union, that is another condition where vertebroplasty needs to be considered. Also, if it's a pathological fracture because of a tumor where a palliative surgery such as injecting cement is to be considered, as in the multiple myeloma, then that are other indications. Definitely, vertebroplasty comes with its complications. There are some immediate complications like an extravasation of cement into the epidural space, which can lead to neurological complications, an extravasation of cement anteriorly into the paraspinal veins, which can lead to other serious complications. There is also the chances of extravasation of cement into the superior inferior disc space. This, apart from the fact that there are certain hypertension which can happen while injecting the cement because of an embolus which can be thrown up. There are some delayed complications, that is an adjacent level fracture which can happen. Also, the vertebroplasty injected bone, if there is a fall in the future and if that bone gets affected, the cement does not get integrated into the bone. So the chances are that the cement block can sometimes hit your pulse. You should definitely not consider a vertebroplasty when there is a severe osteoporotic fracture which can lead to stenosis and there are neurological symptoms because of it. If there is a burst type of fracture pattern where the cement can get pushed out or can get extravasate very easily, you should not consider a vertebroplasty. More than 60-70% collapse where it will be very difficult to negotiate needle into it and put cement, definitely you should not consider doing a vertebroplasty. Apart from the routine things that you should not do a vertebroplasty in a traumatic fractures. There are some cases where it depends upon whether the vertebroplasty needs to be done or not, depending upon the surgeon's preference. If the fracture is less than 3 weeks, but if the patient is severely non-ambulatory because of the pain, is not able to walk, and is having comorbidities, then you can consider doing a vertebroplasty in such cases. If the collapse is more than 50% and in X-ray and MRI it appears difficult to negotiate a needle, but if the surgeon has an adequate experience of negotiating it, then it can be considered. More than 2-level fractures, depending upon what is the extent of collapse. If the collapse is not severe and you feel that you can inject 3 to 4 cc of cement into every vertebral level, you can consider it. 3 levels is maximum that I've done at one time. A junctional level where there is a compression and there is minor cord compression without any severe stenosis and no deficits, you can consider doing a vertebroplasty. At the higher level, about D6 or D7, if you feel that the pedicles are adequate and where there is no severe compression of vertical compression of the osteoporotic fracture, and you will be able to inject an adequate amount of cement into it, you can consider doing it. So these are the cases which depends upon the surgeon's preference and his experience. So how does this vertebroplasty help? So actually there is no confirmed theory in how it works, but one of the theory postulated is that the heat generated by injecting the cement causes neuroablation of the nerves leading to pain reduction. What would be the ideal case to start if you're doing a vertebroplasty? The fracture, if it's between D11 to L3, the vertical compression fracture should not be more than 40 to 50%. You should have an intact pedicle so that you can easily pass the needle lid and with an intact morphology of the vertebra. Definitely not any burst fracture, so that there should not be an extra recession of the cement. And if possible, at least 2 to 3 weeks of period of conservative trial post this fracture should have been done. Some investigations which are necessary before going through the vertebroplasty procedure is, apart from the supine X-ray, see if you can get a standing X-ray. This is necessary so that you can determine the amount of collapse. After doing a standing X-ray, you can also, if possible, get a prone X-ray, because if in the standing X-ray you find that the collapse is significant and you're not sure whether you'll be able to pass the needle or not, then in the prone X-ray, if it's possible, you will be able to see whether the fracture is opening up. An MRI scan is mandatory because this will show the fracture pattern and the morphology, also to say whether the edema is present or not, because if it's an old fracture, definitely it will not accept any cement in it. And if you're not sure whether the fracture is a burst or not, get a CT scan done. Apart from that, the other investigations are, if it's a multiple level fracture seen at the same time, get a serum electrophoresis done to rule out multiple myeloma. You can do a bone densitometry to see what is the bone density, DEXA scan to see what is the bone density, and post-treatment, post-vertebroplasty, any medical management that is required. Also, if the routine investigation, serum creatinine and all, INR, which is required, because procedures are usually done under local and sedation. You require a proper sterile OT and a C-arm where you can easily see an AP laterally properly. If you have 2 C-arms, then it is also reduces your operating time significantly. Make sure that the temperature of the OT is properly controlled. It should be between 18 to 20 degrees. These procedures are done under local and sedation. You should have a proper good anesthetist who can give a proper sedation without making the patient too sleepy. You may require a deep sedation only when you're injecting the cement, because that is when the patient may experience some amount of elevated pain. If you're doing more than 2 levels at a single sitting, you can use 2% xylocaine mixed with adrenaline, or 2% xylocaine is enough if you're doing at a single level. If you want to use a dye after putting the cement in, after putting the needle into place before injecting the cement, you can use an Omnipack or a Eurocapsule dye. So the technique basically involves advancing a J needle or a Cook's needle through the pedicle, through the 3 o'clock or 9 o'clock position, depending upon the pedicle. And under C-arm guidance, you advance the needle up to the anterior 1/3 part of the body. Once the needle is confirmed in that position, in APN lateral view, you can use a dye to inject into that space first through the needle to make sure that there is no extra recession. Once everything is confirmed, you can just pass the cement into that needle. About 3 to 5 cc cement can be easily passed. So, an illustration of it, this is where we start at the 9 o'clock position. You usually inject a little bit of local around the lateral part of the pedicle, and this is where we make a stab incision in the skin adjoining to that lateral part of the pedicle. You can advance the Jamshedi needle up to the lateral part of the pedicle in the AP and the lateral view so that we get a good hold. Further advancement of the Jamshedi needle in the AP and lateral view should be done under proper C-arm guidance. Make sure that the Jamshedi needle travels through the pedicle as it travels through a small cylinder. So always make sure that the Jamshedi needle is positioned into the AP and lateral views in the final position before advancing further, it should be in the medial part of the pedicle and should have crossed the posterior vertebral line in the lateral view. As in this, yeah. The final placement is it should be in the anterior 1/3 part of the vertebra, and once it's confirmed there, you can just inject it and check the spread. To illustrate, you should have the C-arm and a technician who can show a proper AP view where the pedicles are both seen properly. You can always orient the C-arm in such a way that the pedicles are seen properly and you see a dead AP and a dead lateral view. Then in the AP view, inject the local around the lateral part of the pedicle, 2% xylocaine. If you're doing more than 2 levels, you can use 2% xylocaine mixed with adrenaline. After injecting the local, give it sufficient amount of time for that local to act. So maybe after a minute or minute and a half, you can just with a stab knife in 11 gauge or a 15 gauge, make a stab incision on the lateral part of the pedicle adjoining the skin. Then with the Jamshedi needle in the AP, you can start advancing it up to the lateral, in the lateral part of the pedicle in the 9 o'clock position. Check in the AP. Usually sometimes this osteoporotic vertebra have a very weak bone and the needle can suddenly give way. So in the lateral part of the pedicle in the 9 o'clock position, make sure that the needle gets a proper good hold. Once you're satisfied with the hold, then you can ask the C-arm technician to rotate the C-arm and make it lateral view to make sure that the needle is advancing properly in the lateral view. It's not too superior or inferior. So once it's confirmed in lateral view that the position is proper, you can advance the needle further. So you can keep on doing twisting movements and rotating movements to advance the needle in osteoporotic this thing. Need not always hammer it unless there is some amount of sclerosis present, if it's a little bit old fracture and you need to push the needle with force. Otherwise, majority of the times with a twisting movement, you can advance the needle further. So always keep on checking the AP and lateral views to make sure once it is positioned properly where the needle is placed, yeah, in the lateral view in the anterior 1/3 part of the vertebral body. You can just do a final arrangement so that the needle is placed there, and once it's confirmed that it is there, you can just check it. That does not give it this thing. I usually do it with this thing. So this is where the final placement of the needle should be, in the anterior 1/3 part of the body. And I usually don't inject any dye into it, but if you want, you can inject a dye to make sure there is no extraversion of cement going to be. Then you can start mixing the cement and inject the cement in a semi-solid state. Usually 3 to 5 cc of PMM cement can be injected at one level through one pedicle. Do it under continuous fluoro and don't all push the cement in so that it does not extravase it out. This is how the final picture appears after doing a single level vertebroplasty. Once the procedure is done, remove the Jamshedi needle, allow at least total setting time of the cement should be around 15 minutes. So give that much amount of time till the patient remains prone. Once that time has elapsed, the cement has hardened exteriorly, then you can just put a small dressing, a sterile strip over it, and then make the patient supine again. Thank you.
Thank you, Nikhil. That was a very nice presentation on the technical aspects of vertebroplasty. We invite questions.
I think one practical question which people would want to know, Nikhil, is which cement are you using right now? Which cement do you use?
So I basically use the Medtronic cement or the Biomet cement now. The PMA.
So just as a cost saving measure and as something just to say which I have been using for the past 15 years and I don't change very easily. I use actually Simplex P. So I use Simplex P cement, and what I do is I take out 1 teaspoon of the powder and I put 1 teaspoon of sterilized barium powder. So from the radiology department, I get barium powder sterilized and they are in little sachets, and I do that and I mix it. So I'm completely used to the feel of that cement, and therefore I don't use these other cements. When I started out, these Depu cement, etc., cost 40,000 rupees, and Simplex P cost 2,500. But I believe these cements have also become cheaper now. So if you're used to using those, it's fine. But I'm used to Simplex P now.
The costing cement is around 10,000 to 12,000. But any benefit that you use Simplex, I mean, with that barium, anything you notice different?
No, there is no advantage. I mean, obviously the licensed and the ones which you use are obviously the right ones to use. But I'm just saying I've been using these and I have had no problems at all with that. I'm very used to using it.
There is another cement called Spineplex by Stryker, which is Simplex with the barium added already. It has a longer setting time, which I really love to use, and it costs about 6,000 rupees. So for 2,000 rupees extra, the headache I find with the Simplex is not worth that amount. And I've discussed it in my talk also, that why I use it in that way.
Yeah, there is a question from the delegates. Oh, it has been taken off. What he was asking was, do you use extrapedicular approach?
I think I have a mistake. So I use extrapedicular approach for the upper thoracic level, where the pedicles are very narrow and where you may not be able to get a good entry into that. But mainly D11, D12, below that you don't require. I mean, you can easily approach from one side, and you can easily navigate the needle to get a midline of this thing, and you can have the cement which can be pushed throughout the vertebra. So I usually do only a unilateral pedicle entry. I don't do a bipedicular entry. So regarding that Simplex, so today, just now I did one vertebroplasty and I came, but that Simplex, have you seen that if you were to take out the needle, a strand of that cement sometimes comes out? I mean, you get like this thing. Have you noticed?
No, so it basically, that can happen with any cement. Basically, if it is liquid and you take out your needle, there is going to be a cement which comes out. So I don't take out the needle. I don't take out the needle unless the cement is set.
Yeah, so I also take it out after 15 minutes to 16 minutes.
Yeah.
But still, I get that entire plug in the last 2 Simplex. So I have now decided not to use Simplex.
No, I haven't seen that. I've seen that once. Like it has happened to me once when I delayed to put the plunger inside, and then there was a little stick remaining. I couldn't put the plunger in. But other than that, I haven't. Like I said, they say in Hindi, they say मेरा हाथ बैठ गया इसके ऊपर. So इसके ऊपर मेरा हाथ बैठ गया. I'm just used to it. Like so I've been doing it for the last 15 years. So.
Yeah, I think when you withdraw the needle, the initial withdrawal should be like about 2 millimeters, and you see what's happening. If you see something, then maybe you can wait a little longer to withdraw. That's what I do. That withdraw the first 2 millimeters, watch what's happening, and then withdraw the rest of it.
So I withdraw it when the cement. See, I withdraw it when the cement outside is set. When the cement is set outside, then the cement inside is 100% set, because inside the temperature is higher.
Correct.
The temperature is higher. So when the cement outside sets, that's when I take it out. The only thing is when you take it out, you have to twist the needle slightly and pull it out, because otherwise it can get. So maybe that is one issue, Nikhil. You need to twist it slightly so it breaks off and then pull it out.
So good afternoon, everybody.
I don't know. The last 2 cases, like today also I did one, and maybe last week I did. So that same thing happened. That entire plug-like thing came. I don't know why it happened. Maybe that Jamshedi which was using, it didn't have those flanges like it was a smooth rounded one. So I don't know whether it was cutting that.
Nikhil, very well presented. I just want to ask you your experience, whether you do it under general anesthesia or local plus sedation or only local.
So I do it under local and sedation, but since the last some 5-6 cases, what I've started doing is I have asked the anesthetist to give an erector spiny block and local, and if required sedation, but they are doing very well with erector spiny block and only local. You require actually no sedation for these people.
So what is for everyone's benefit, what is the advantage of this?
Oh, what?
What is the advantage of not doing under anesthesia? You're doing just a block and
Yeah, I mean, see, basically, if you want to give general anesthesia, most of these patients are geriatric. They have comorbidities, so you have to go to the entire regime. They may have poor ejection fraction. They have cardiac thing. It becomes very this thing. I mean, this is hardly a 20 minutes to 30 minutes procedure inside the OT. So for that, giving a GA and to get the entire fitness and all evaluated is a big this thing.
Correct. And you can check the neurology also on table.
No, I think essentially, vertebroplasty is like a salvage procedure. It is something to be done for very moribund patients, where you actually don't want to give general anesthesia. So I feel, if you give GA, probably a little bit of the purpose is, jeopardized.
Right. And
So
you can check the neurology on table also. You can ask the patient.
Right. And
Neurology to assess, I mean, unless your cement is extravasated posteriorly, I mean, you don't anticipate anything going to this thing, or you have needle has traversed very medially and gone from one side to the other. I mean, I don't think so that we have got, if your needle is placed safely and your cement is in the anterior 1/3 and middle part only located, it should be any neurological problems.
Okay. And I just want to ask, you mentioned in some cases where there is a lot of pain and patient is not better, one can consider vertebroplasty.
Yeah. So actually today's case which I did, she got admitted yesterday. I had counseled her for conservative management 4 days back, but she was in so tremendous pain even with IV injections and with even DEXA and all everything round the clock. We had put a patch also. But for the last 2 days, she was totally crying and howling in pain. So that's why I had to go and do it. So I would say that, I heard a part of what Dalvi sir said. I would definitely want to give a conservative trial of 3 weeks before deciding for any procedure. But sometimes you have these patients who are so bedridden and they are having comorbidities, and even after giving the best of things, they're not having any relief of pain. You will have to do something. I mean, these are very exceptional cases, not the routine.
Only very exceptional cases you will prefer. Otherwise, you will also be perfect.
Shailesh, Dr. Bhave sir has raised his hand. If he can.
Yes. Yeah, 2-3 things I would like to add on it is, one is you have to give local anesthesia up to the periosteum because it is the pain sensitive structure, number one. Number two is when you put the needle, try and aspirate, send for cytology because we had surprises. We had diagnosed thyroid cancers, CA stomach and many multiple secondaries from this aspirate, even amyloidosis of liver, which caused pathological fracture of this. So when you are putting in the needle, it is better to aspirate, do the send it for cytology. That is the best advice because all of these are old patient and is cancer age group. We should not miss. Or even once we had tuberculosis, we got pus and we had to stop that procedure. Third is doing venogram. Venogram is safest thing what a surgeon can have on table. If your veins are directly communicating with Patson's venous plexus, then it is better to change the tract or even change the pedicle. Don't inject the cement. And even still, if you want to continue, you just push the needle little anteriorly and then inject only when it becomes a consistency of more than a toothpaste. Then only there are less chances of leaking. But safe thing is to avoid when it is communicating with the venous plexus. We had an advantage, we had an experience also, the cement leaking. We could immediately open it and do the thing and patient was not paraplegic at all. But these are rare exceptions, but to be on the safer side, to have safe spine surgery, it is always better to have injection of a contrast, remain safe, and then you can have better results. And then simultaneously, if you inject the facet or the facetal joint, patients have got very good long-term pain relief because facetal arthritis or facetal overloading because of kyphosis, that is also one of the pathologies which cause fracture pain, which patients have pain along with the fracture. So these few things, if you could add, you will have finally better outcome. And what Samir and Nikhil was saying about cement coming in along with the needle track, technically it is called as fishtailing. So you have to, before removing the needle for a minute, you have to keep on rotating the needle in place without removing it see that that cement needle doesn't get stuck in that cement mass. And then once it is free to rotate, slowly withdraw it by millimeter, see that cement is not coming back in the tract. And then only once you reach the posterior body, then you see, check on the C-arm that it is not coming back, and then only you should remove. Because fishtailing sometimes can cause nerve root irritation, because there is inadvertent fracture which already occurs at the time of injury, and if it is not healed, the liquid monomer can come out through that fracture and irritate the nerve root. So that is a safer thing what you can do while you are removing the needle. So these are the few quick suggestions what I had from my side.
Great suggestions, Dr. Bhave, and it's the words of wisdom from Dr. Dalvi and Dr. Bhave we have. And I think there are a lot of questions which we will have to take, and we'll have to proceed with our session as we are running out of time. I would like to invite Dr. Varun's presentation next on kyphoplasty, and we'll continue our discussions in the meantime.
Thank you, Dr. Shailesh. Can we have the video, please? Very good afternoon to all the participants attending this talk and ASSI for inviting me for this lecture. I am Dr. Varun Kumar Agarwal, Associate Professor of Orthopaedics, Rohilkhand Medical College and Hospital, Bareilly. When we talk about osteoporotic vertebral compression fractures, we should all remember that it is the kyphotic deformity and not the acute back pain which accounts for all the long-term consequences. These osteoporotic fractures leads to back pain, spinal deformity, decreased lung capacity, impaired function, loss of appetite, decreased activity, increased fracture risk, increased lung problems, comorbidities, and up to 23% increased mortality. And this is the downward spiral associated with these fractures. Kyphosis shifts the center of gravity anteriorly, and this increases the stress on the anterior part of the vertebral body, leading to more kyphosis. There are adverse mechanical effects of kyphosis, such as increased vertebral body stress, increased facet stress. All these increases the back pain, and there is decreased thoracic space, decreased abdominal space, there is shifting of the center of gravity, there is a compensatory stance. All these leads to a deformed and impaired pulmonary function. The patients who suffer the vertebral osteoporotic compression fractures have an increased mortality risk as high as twice that of the normal population in that age group. So when we talk about basic principles of any fracture management, the first principle is fracture reduction even before fracture fixation. Vertebroplasty is fracture fixation, whereas kyphoplasty is fracture reduction followed by a fracture fixation. The balloon in a kyphoplasty acts as an enclosed space in which pressure is being applied per unit area, which generates a force correcting the deformity. So in summary, the compacted bone is forced outward into the pore spaces. The inflatable balloon tamp inflation displaces and compacts the cancellous bone. Cancellous bone stiffens and moves as a mass, transferring force to the surrounding cortex. The cortex then moves back to its normal configuration, increasing the height, and the end plates become more parallel. So before we move on to the procedure, we should know how to select a good candidate for kyphoplasty. The patient who tends to respond best are those who have 1 to 3 levels of fracture. There is a focal pain and tenderness corresponding to the level of edema on MRI. The fracture is present for less than 2 months. There is a recent worsening of fracture, and there is no sclerosis of the fractured vertebra. A poor candidate is the one who has fracture for more than 1 year. There are other causes for back pain such as a disc herniation or a spinal stenosis or facet or sacroiliac joint disease. There is a radicular pain related to a disc herniation. All these are poor candidates for kyphoplasty. So these are the instruments and how to set the table for the procedure. We use 13 gauge bone biopsy needles, and we use Luer lock syringes so that we can have a good fixation of the syringe to the needle and there is no leakage of any substance. We do the process under IV sedation or local anesthesia, in which we use 1% lignocaine with adrenaline and 0.5% bupivacaine on the bone. General anesthesia is rarely required. So the main advantage of local anesthesia is that it allows the surgeon to communicate with the patient and to determine the cement injection speed, anticipate any corrective measures that need to be done, and abort the procedure if any problem is happening on the table. While the local anesthetic is acting, we give an injection of antibiotic along with painkillers and perinorm preoperatively. And personally, I prefer to use a nasal cannula, as I find an awake patient is more acceptable of a nasal cannula than an oxygen mask, and it provides a sensation of comfort to the patient. The patient is monitored and IV lines are established. There is continuous intraoperative monitoring with ECG and oxygen saturation, and always remember not to treat this as a casual OPD procedure. So this is how the patient in the room is set up. The patient is to be placed in extension using radiolucent surgical tables or even bolsters can. The patient is placed prone with padded rolls, and the lower legs are also padded to remove pressure from the fracture and to prevent any sores. Make sure that the patient is lying comfortably and squared up on the table. And prior to the skin incision, always check that your fluoroscopy is adequate and you can visualize all the bones properly and the symptomatic vertebral body level is visualized. And please be aware of any deformity and obesity. The patient is prepared with meticulous sterile technique. One should not treat it as a casual OPD procedure and follow all the sterile precautions as in a normal surgery. Then coming on to radiographic images and its interpretation. So this is the true AP image in which the pedicles in the upper half of the vertebral body, the spinous process is equidistant between the pedicles and the end plates are parallel to each other. So similarly, a true lateral view is needed in which the pedicles are superimposed on each other and the end plates are parallel. So this is a short video of the procedure. So this is a case of a 75-year-old lady with pain in the back and bedridden for 4 months with an osteoporotic compression fracture at L1 level. So local anesthesia is given and a Jamshedi needle is inserted. The pedicle is targeted under AP view and it is slowly advanced after confirming in the lateral view. The needle is again advanced to be in the body. And once it is placed in the body, then we remove the stylet and place a guide wire and exchange this Jamshedi needle with the working cannula. You can gently tap the guide wire so that it doesn't displaces. And now we remove the Jamshedi needle. Carefully, not to displace the guide wire. You can hold the guide wire with the help of a forceps. And then the procedure is repeated on the opposite side. Local anesthetic is again given. And the Jamshedi needle is first placed in the AP view and then confirmed in the lateral view. And when you have adequately cannulated the pedicle, you can again put in a guide wire and exchange the Jamshedi needle for the working cannula. So you can aspirate the edematous fluid in the fracture cavity, which is seen on the MRI, which confirms that the needle has been placed in the correct position inside the vertebral body. And you can send it for biopsy or culture. Another tip is to inject the normal saline in one needle and it comes out of the other needle, which confirms that both the needles are in the correct position inside the vertebral body. And then you can just aspirate this normal saline to make the cavity dry again. So next is to inject radio-opaque dye to confirm whether there is any leakage or not, and if the dye is well contained inside the vertebral body, one can be reasonably sure that the cement is not going to leak. And you can confirm this both in the AP and the lateral view. Then the balloon tamp is readied for insertion. You fill the inflation device with the normal saline mixed with the radio-opaque dye to make the balloon visible during the procedure. So we load the balloon inflation device with normal saline mixed with the dye. Then remove all the air bubbles. Then insert the balloon catheter through the working channel inside the vertebral body. The inflation device is attached to it. And then slowly the balloon is inflated and the height of the vertebral body is restored. So as we inflate the balloon, the height of the vertebral body gets restored. And we can do this gradually, slowly and under control. Then the balloon is deflated and withdrawn. The procedure can be repeated on the opposite side, or one can use two balloons simultaneously through both the Jamshedi needles. And again, gradually and slowly inflate the balloon to restore the vertebral body height. You can do this under intermittent or continuous fluoroscopy. And then remove the balloon catheter. The cement is then injected using a cement filler device through the working channel. This allows a controlled delivery of cement, and you can do it under live or intermittent fluoroscopy again and see how your vertebral body is getting filled up with the cement. And there is no leakage, and at that point you can stop. Try to fill the vertebral body from anterior to posterior in a gradual manner. And to prevent any leakage, go gradually towards the posterior side. The final confirmation can be done in the AP and in the lateral views, and shows adequate filling up of the cement in the vertebral body after adequate height restoration. These are the final check x-rays, and the patient is mobilized the next day of the procedure. And you can see how comfortably she is out of the bed and walking. Initially with the help of a walker to give her confidence, and then as tolerated, the walker can be discontinued. To economize the usage of cement and use the same packet of cement in multiple vertebrae, one can take out the cement powder in a 50 ml syringe and the liquid monomer in another 20 ml syringe, so that we have 1 ml liquid for every 2 milligram of the powder. And then the video shows how to mix it. So in this video, I have taken out the powder in a 50 ml syringe and empty around 20 milligram of that powder at one time in a bowl. So this allows us to be very precise in the measurements. And a 20 milligram of powder is emptied into the bowl. And the rest is set aside to use subsequently in another vertebra if it is needed. You can set aside the powder for a subsequent procedure on the next vertebra. And accordingly, the required amount of the monomer is poured inside and then mixed. So in this way, the same packet can be used for multiple levels. Post-operatively, the needle site is dressed and there is strict bed rest for 2 to 3 hours with monitoring of the vital signs, and a neurological examination is done. The patient is discharged 3 hours after the procedure, and follow-up is done on the next day, 1 week, 1 month and 6 months after the procedure, and it can also be done over the telephone. So my protocol for these osteoporotic compression fractures is I do it in cases less than 6 weeks old who need to be hospitalized, or there is a failure of conservative treatment after 3 months. I choose vertebroplasty for all, except when the middle column is involved. I tend to go in for kyphoplasty, where I need to increase the vertebral body height. So vertebroplasty, it is quicker and cheaper, but kyphoplasty, although it is expensive and takes longer, it restores the vertebral height. There is less chances of adjacent fractures, there's less cement leakage, and there is an increase in quality of life more in kyphoplasty than in vertebroplasty. However, both of these procedures must be treated with the respect, as its application without appropriate preparation and physician knowledge can quickly produce increased pain, permanent neurological injury, and even death. So always treat these procedures with respect and due precautions, which we take for all surgical procedures. Thanks a lot for a patient hearing.
Very well presented, Dr. Varun. Dr. Varun Agarwal has shown the technique of kyphoplasty and the advantages of kyphoplasty. And there was a recent publication, and it's a meta-analysis which is talking about kyphoplasty versus vertebroplasty by Wong et al. And they have mentioned that the height restoration is better in kyphoplasty, and also the chances of cement leakage is better in kyphoplasty. But the ultimate outcome, the results are same of vertebroplasty as well as kyphoplasty, because it has not mattered in their meta-analysis, the outcome basically. What's your take on it, Dr. Dalvi?
What take do you want exactly?
No.
So if I can be very harsh and direct. And I think kyphoplasty has no role whatsoever. I mean, I think it's just one nice thing invented by companies and by people to make people happy, make surgeons happy, and make patients and companies happy. You're just doing too much of a thing and making a big hoo-ha for a very small, tiny thing, which also doesn't work. So vertebroplasty itself barely works. On top of that, you want to create a kyphoplasty under some vague sort of excuses like height restoration, etc., which actually doesn't happen, because when you put patients prone in vertebroplasty, also there's height restoration. You end up putting more cement. So actually more cement is bad, which has been clearly shown. So the adjacent fracture rates are not going to matter much, genuinely speaking. And the time taken is much longer. The cost is more. The complication rate is higher. It's a very exacting thing. A vertebroplasty is fairly simple. But for a kyphoplasty, you have to really, really get your needle bang center to be able to dilate and put the thing. Because if you don't have a needle bang center, you can't just inject cement. It has to be bang center to get your balloon bang center and do it. And it is recommended that this is done under, I think he's done it under local, Varun has done it under local, but it is recommended that it's done under general anesthesia because it takes longer. So I really see no role of a kyphoplasty in my practice. Like I did a couple just as a lark, but I really don't think there is any role in it.
Okay, we got the message from Dr.
No, so my message is very harsh and it may be wrong, but That's what I think.
And it is his personal experience. I would like to ask Dr. Arvind Bhave about his experience about kyphoplasty. See, this is not against anyone. This is just everyone's personal experience. And Dr. Varun also has mentioned that he has done it in only selective patients. He prefers to do vertebroplasty. So let's see, Dr. Bhave.
Yeah, he's made it clear. He's made it clear.
Yeah,
He's made it quite clear.
Yeah, Dr. Bhave, yeah.
Yeah. Actually, Varun has nicely demonstrated in his video. Only thing is, if you are using two balloons, then they should be used simultaneously. Because if you are using one balloon, deflating it, taking it down, that means you are allowing that vertebra to collapse back. And then again putting the same balloon on the other side is not the ideal philosophy of kyphoplasty. So if you are putting one balloon, you have to inflate it gradually. It is not a sudden inflation, so that actually the philosophy is the marrow crumbles and it makes the periphery of the void more thick so that it can accommodate more and more cement. That is one. So if you are putting one balloon and inflating it, put another balloon, inflate it, again increase the pressure in the first balloon, again go on increasing pressure in the second balloon, so that you don't create a scoliosis. One balloon inflated so much and another balloon inflated so much. Final end product will be the the scoliosis which will be created, because once that is a void created by, or it is a iatrogenic void. So if you are creating two unequal voids, then naturally there is going to be a scoliosis. So if you are using two cements, then better is to use alternatively, increase the pressure simultaneously. That is the philosophy of kyphoplasty. And because you are deflating the balloon again and removing it, so you are giving a chance for it to collapse. So what happens in old fractures, there is increased pressure developed inside the vertebral body. As against in fresh fractures or fractures within first 6 weeks, we have studied the pressures inside the vertebral body, and what it suggests is more the time period is passed, then there is increased intravertebral pressure developed. And once you try to inflate that with your pressure gun or whatever scale you have in the hand, and if you suddenly deflate it, everything collapses back because there is a lot of pressure inside. And hence, that is a chance of, that is where this philosophy of kyphoplasty is going to fail. So for fresh fracture, like for any fresh fracture, we try to do close reduction, align them properly anatomically. So earlier you do, you are going to have better results. So that is a philosophy. So I support the philosophy, no doubt, because it is a basic of orthopedics that you have to have close reduction, have normal anatomical alignment, so as to have better outcome at the end.
Thank you, Dr. Bhave, for your experience. But I would like to ask Ankur, what do you think about it?
So actually, I partially agree with Dr. Samir, and I think Dr. Bhave has already brought out what I wanted to say. So I think vertebroplasty and kyphoplasty, they are both procedures which are very similar, but I think it is to be very intelligently used which fracture you want to use, what procedure. Yeah. It is very, so over the last 10 years, we have learned a lot, and a lot of us have burnt hands with cementing these fractures. Now we know which fractures not to cement at all and whom to, basically fix. So we know that fractures which are very crushed, which have a middle column involvement, which have a big kyphosis, they are likely to fail with kyphoplasty alone or a vertebroplasty alone, and they're better off with the fixation. I totally agree with Dr. Bhave that kyphoplasty has a more role in a fresher fracture, wherein you can create some space, impact the fracture spaces with the opening of the balloon. Because one thing which we are forgetting is there is a lot of literature on extravasation of cement leakage. And in a fresh fracture, if you inflate the balloon, the crevices of the fracture get impacted, and you can fill up the cement under a low pressure. But if you try to do the same thing in an old fracture, it doesn't make sense. So kyphoplasty should not be used in an old fracture where a Kummel's lesion has already been created, and it is better treated by a cement alone with a vertebroplasty. Having said that, at the same time, I think kyphoplasty does not cause any correction in the kyphosis, It's more of a theoretical and a marketing, statement which was made. The most of the correction of the kyphosis does happen with making it prone. So my reason of using kyphoplasty is basically to reduce the extravasation of cement problem, and it can be easily done under local anesthesia. We never do kyphoplasty under GA, and it is done within 30 to 35 minutes. It doesn't take long.
Point well taken, Dr. Nanda. Excellent explanation that mainly for cement leakage, this is the procedure of choice, and that's what you want to say in a fresh fracture. Yes, Dr. Varun, now we would like to hear from you, and then we proceed to the next talk.
So I totally agree with Dr. Bhave that the ideal situation is to use 2 balloons, but there is an additional cost to it, and sometimes in India we are constrained with that on that account. And so that is kind of a in between make do, which we do it alternatively. Ideally, it is to do to use 2 balloons. And personally, where I prefer kyphoplasty is that it allows me to do some more advanced, maneuvers during the procedure, which vertebroplasty alone sometimes doesn't allow. Like Dr. Nanda has said about the compaction of the cancellous bones, and some correction is there. So if at all it is indicated, I usually do prefer kyphoplasty over vertebroplasty, and I have had better results with the patients with just vertebroplasty alone.
A great presentation,
Doctor. Can I add one thing?
Yeah.
So in case there is an economic restriction, we can try using extrapedicular approach, because where you can go from one top to another bottom, diagonally opposite. So one oblique cavity can take care of 2 balloons. So if you're really thinking of cutting the cost, then use extrapedicular approach that we can do right from T4 to L4 without any problem. And L5 also we have tried. Only thing is, on one side there is a vein, sometimes is more prominent, you might miss it. So you have to be very particular. But from T5 to L4, safely, many times you can use extrapedicular approach just to save the cost with similar results.
Thank you, guys. It's a wonderful presentation, and in view of time, we'll have to go to the next presentation, Dr. Arvind Bhave. And
take a question in the meantime till the presentation comes.
Yeah, we can definitely take.
There is a question from Dr. Rahul who's asking, what pressure do you set for kyphoplasty, or does the pressure matter for you? And the other thing is, what is the role of kyphoplasty in metastatic vertebral fracture? Can you take both the questions?
Yes, Varun.
Metastasis, I'm a little scared to use this balloon because it may be pushing the tumor out, and I'm not sure where the mets are going to lie. So for that condition, I would preferably go with vertebroplasty alone. And as regards as the pressure, I think gradually you can, by the feel of the vertebra, how much it's opening up. And there is a pressure limit onto the device also, which allows you to put the pressure there. I think Dr. Bhave can...
In our research study, what we have done is we have studied inside the vertebral body, at what duration, how much pressure is generated. And it is related with the weight of the patient, osteoporosis, and so many multiple factors which increase the permutations. Important thing is external at room temperature, in any atmosphere on Earth, the temperature is 1 atmosphere. So we have to always go above 1 atmosphere. That is a basic physics. So until and unless you measure it, so first resistance what you get when you start injecting is, if you are putting it easily, there is no need of going above 1 atmosphere. But if as the pressure grows older, there is a lot of fibrosis around, and then you have to go on increasing the pressure for deflating or inflating the end plates. So 1.2, 1.4 newtons per meter square, that is ideal, because beyond that, in osteoporotic fracture, you can add new cracks. That is what is our finding from cadaver and mechanical studies and computer assisted studies. So for our Indian vertebral bodies, I feel 1.2 and maximum 1.4 newtons per meter square pressure is good enough to have good jacking up of the end plates.
Thank you, Dr.
And for the problem in malignancies, that is why we had to develop a new implant, and that I will be speaking in my next presentation.
Yeah, kindly load Dr. Bhave's presentation on vertebroplasty.
And in this, we are able to inject chemotherapeutic drugs also along with the cement. We are now using biodegradable cement. So in younger patients also, it is possible for stable fractures. For that, you need not have instrumentation and causing problems in their backs, destroying their muscles. You just have one needle and that is done your job. And after 6 months to 1 year, that cement also disintegrates and you just have a normal vertebra. So that is going to be the future.
Okay. Kindly, yeah.
Good afternoon. Welcome to this session of osteoporotic compression fracture treatment. Today, I will be discussing with you and sharing a video about vesselplasty. This is third generation procedure of vertebral augmentation by minimally invasive modalities. As you know, the rising age all over the world is causing more and more aging people and hence more and more degenerative disease. So osteoporosis is not an exception, and hence more the osteoporosis, more is the osteoporotic fractures and related problems. This is a picture shared to me by Professor Lieberman, who has done pioneering work in vertebroplasties. So as you know, once osteoporotic compression fracture occurs, it leads to increase in back pain, spinal deformity, decreased lung capacity, impaired function, affecting many problems like GIT affection, sleep affection, decreased activity, which itself causes further bone loss, increased lung problems, increased comorbidities, leading to about 23% of mortality. And then another problem of deformity progression. This has been proved in a paper by Lieberman, which is published in Spine Journal, which has taken the same case, 2 X-rays taken, first on 31st August, which shows that there is a compression fracture, apparently stable, and just X-ray in a following week shows that the kyphosis or the deformity is progressing, which we never usually understand if we don't do serial X-rays of the patient. And hence, deformity progression is one of the important problem in consideration of the treatment of osteoporotic vertebral fractures. And hence, aim of the management of treatment is to cut down the downward spiral to improve the quality of life of the patient and correction of the deformity using minimally invasive techniques. So what are the issues of vertebral augmentation? First and foremost is to prevent cement leakage. That is, a safety factor is much and single important factor in any spine surgery. Second is to, if possible, restore vertebral height and provide interdigitation effect so that stability of the fracture remains. And hence number of procedures have been developed and they are going to be developed henceforth also as research advances. So it initially started with the index procedure of vertebroplasty. Then people thought of improving the height of collapsed vertebra, and hence numerous procedures are being developed. Famous amongst them were the Sky Expander, Optimesh, and VEX 3000. Then using a void, by creating it by using kyphon balloon, that is a kyphoplasty, that has been popularized world over nowadays. And today I will be able to talk to you on another modality where we don't create void, but the hydrostatic pressure inside the implant causes increase in the height, and that is called, the procedure is called as vesselplasty. So this is one of the non-fusion technology which is coming up. So what is vesselplasty? It is a further step of kyphoplasty technique, which is a non-fusion technique using an implant body expander, which is called as vessel X container system. And it is a third generation implant which has been developed in particular procedure. So the design, it is an implant. It consists of a PET material non-stretchable container. So it has got a fixed size of implant. So it prevents leakage. Second is it has got pores of 100 micron, which allows limited cement coming out or exclusion of the cement across the implant to hold or interdigitate with the vertebral bone marrow. And third is, as you put the implant and put the bone filler material like cement, then implant itself expands, and as it expands, it restores the vertebral body height. So it is a non-stretchable PET container. In a deflated position, we can insert it through a vertebroplasty needle. And as you go on injecting cement, it expands to its predetermined size. And interdigitation can occur of the bone filler material, which will have better hold on the vertebral bone marrow. So it works by 3 phases. One is pure lift, because the container is inside the vertebra, so it has got capacity to lift the end plate. Second, interdigitation. It is a controllable vertebroplasty, allowing bone filler to fill the void. And third is implant itself is a implant body expanders. And hence all the 3 things have been achieved, and hence it gives you better results and better correction. Now we are just recollecting how we have come to this particular thinking. In vertebroplasty, which is a minimally invasive surgery, which instantly relieves the pain, improving quality of life. But the disadvantage is it does not try to restore the height, it does not create the void, and when cement is injected, it goes on its own. So cement will travel to the weakest area, filling the space, void, or fracture cavities. And hence, there is a possibility of leakage of cement or bone filler material. Hence, to improve on this, kyphoplasty is developed, in which we are using a balloon, which is a non-biocompatible. So it is not an implant. So with the hydrostatic pressure, it creates a void. Once you have it complete enlargement of the balloon, then you have to remove the balloon by removing the fluid inside, and then it creates a void, and then that void is filled with cement. So it is a type of modified vertebroplasty. So sometimes if the pressure inside the vertebral body is more, once you remove the balloon, it will collapse again. As against, the basic differences in vesselplasty and kyphoplasty is, in vesselplasty, it is a non-stretchable material. It is inflatable to a certain size, because we have implant size 20 millimeters, 30 millimeters, 25 millimeters, similar. Then it has got a permeability. So porosity of 100 micron, pores are there through which cement can come out. It is designed to fill the viscous bone materials or any other chemotherapeutic material also. This implant itself is made up of PET, which is a biocompatible material, and is remaining inside the vertebral body, holding it to that whatever correction you have got during the surgery. As against in kyphoplasty, it is a stretchable material, it is inflatable, but you cannot have a controlled size. There is no porosity, it is not an implant. It is designed for liquid and water materials, which are not biocompatible, and hence you have to remove that balloon, create a void, and do modified vertebroplasty. So what happens once the kyphoplasty balloon or vessel is inside? In balloon kyphoplasty, the container size and shape may be deformed, volume fluid is preset, height restoration, you cannot predict how much it is likely to correct. As against in vessel X, the container size and shape is predefined and it is constant. Pressure and volume of the cement is controllable by your injection, and ending of the procedure is justifiable. So whether in a burst fracture, if you don't want your cement to come out of the implant, you need not do it. And hence, height restoration is reasonably well calculated. And hence, there are difference in the results between the balloon kyphoplasty and vesselplasty. As you know, in balloon kyphoplasty, you can see a collapsed vertebra where we have used balloon, inflated. When balloon is deflated, again there is some collapse, and then you inject the cement. So this is a final picture. As against in vesselplasty, this is a vertebral collapse. You have injected, you have implanted, injected, and this is a post-operative CT scan showing nicely fitted implant, and the material has come out interdigitated with the vertebral bone marrow, and there is no long-term collapse after this. And then there are difficult situations where vertebroplasty and kyphoplasty cannot be done. And in these situations, vesselplasty might be one of the best answers as a minimally invasive procedure, which you can do under local anesthesia. This is an example of a 82 years practicing homeopathic physician who had a fall, was treated conservatively. When he came to us, this was his picture, avascular necrosis, pseudarthrosis, cumulus lesion you can see, and there was a vertebral collapse. At this point, we have subjected him to vesselplasty. You can see the implant seated nicely, implant getting inflated as you go on injecting the cementing material. This is at the end of the procedure, AP view on C-arm. This is the lateral view on the C-arm, and this is post-operative picture showing you good correction, implant sitting properly at the fracture site. So this is the beauty of this particular procedure. There is another lady, 68 years, compression fracture L1, which was treated conservatively for 2 months with so much of collapse. She is treated with vesselplasty. You can see 8 weeks dynamic X-ray, inflection extension. There is no instability, there is no adjacent lesion, and if you see her clinical result, you can see hardly any wound seen here, done under local anesthesia, and patient is walking on her own. So that is the beauty. This is another case, 67 years, obese, 150 kg female suffering from L2 vertebral fracture. This is picture in 2003 when we were routinely doing vertebroplasties. So it was treated by vertebroplasty followed by injection teriparatide, had this result, and this lady didn't reduce her weight. In fact, it increased and had fresh fall in January 2019 to have one fracture above after a fall from staircase. And now this time we had vesselplasty, so she was treated with vesselplasty. These are C-arm intraoperative pictures and the final picture here. You can see vesselplasty done. This is immediate post-operative. Along with that, we had given Prolia. First dose was given. This is her post-operative picture. And 6 months after first dose, you can see nice interdigitation, stable implant, no collapse, and she is maintaining well. And almost 120 kg lady, 67 years old. So that is the beauty of this procedure. Everything is done under local anesthesia. So I will show you this procedure step by step. In another lady, this is a picture, treated 1 month compression. So C-arm picture where you are inserting a needle, then drill is passed. We have developed a special device which goes inside, and in case it increases further height, then implant is introduced, AP and lateral views to confirm the positioning of the implant, guide wire removed, and now cement is getting injected. You can see implant is expanding, lifting the end plate. Here is the AP view. This is a final picture at the end of the procedure, and this is a lateral picture at the end of the procedure. So that is how it is being done. So our results, there is good height increase of the vertebral bodies treated. They were pain-free to do activities of daily living immediately. There is improvement in VAS, ODI scores. Whole procedure can be done under local anesthesia, mobilized on the same day and discharged on next day, and discharged with bandage dressing where patient or their relatives can manage at home. I take an opportunity to thank. So to conclude, vesselplasty is a non-fusion technique which is developed to restore the height, so implant body expander, Cement is used in a non-stretchable container to prevent leakage, and there is a possibility of controllable vertebroplasty to fill the void. The mesh pores of 100 micron, they allow some material, some cementing material to come out and interdigitate with the bone marrow of the affected vertebral body. So that is how it gives you final result. And this is pre-op, this is post-op, this is post-op CT, and this is post-op X-ray, having good height achievement and stability of the fracture. So these are the books. Those who want can go and read further from these books, which have been published now in multiple languages. Also, it is available. I thank you for your attention. I take an opportunity to thank all the Assicon team for arranging a nice workshop on osteoporotic vertebral compression fracture. I thank you very much.
Thank you, Dr. Bhave, for a wonderful presentation and enlightening all of us on the new technique which you are doing quite regularly, the vesselplasty.
Yeah, thank you.
I would like to ask Dr. Ketan Badani sir for your views on this technique. What I can gather is this is reasonably a safe technique for prevention of cement leakage, and this has been published in the Chinese literature as well. And recently, a lot of talks are coming from vesselplasty group in comparison to kyphoplasty, and the main advantage is prevention of cement leakage. Otherwise, it is comparable to all the remaining technique. I would like to
and this is an implant. We have to understand this is an implant. Kyphon, people feel that it is an implant, but it is not an implant.
Vesselplasty has an implant. Yeah, vesselplasty has an implant, and we'll come to that also. Yes, Dr. Badani.
Yeah, so principally it's very appealing that in kyphoplasty you actually expand and then you are putting the cement. So there's a time interval where the bone can again collapse, whereas this doesn't happen in vesselplasty. And conceptually, it is good. A second good concept about it is that the pores in the balloon, which allow the cement to leak out a little bit and interdigitate with bone and hold. But my question is that it's still not so popular. What is the reason? Dr. Bhave would know that. What is the reason for it not being so popular?
No, it's popular because just last 3-4 years only we have got US FDA clearance and EU approval. Actually, in Italy, there are more than 2 been done. And in India also we have started, we got permission late. And hence these are early days. So as more and more surgeons see it, get it to be done, they will be able to see the difference and see the results.
So, Dr. Bhave, is this your procedure of choice for this osteoporotic fractures, non-union, or you still do vertebroplasty, or you make a choice?
So, in a case of 100 spinal fractures, if I see osteoporotic, hardly 10 I will be doing vertebroplasty, and 3 or 4 I will be doing vesselplasty.
Okay.
And if it is burst fracture, old patients, definitely I would give preference to vesselplasty, because in case you need fixation, you can do percutaneous screws under local also along with vesselplasty and avoid major surgeries or major GA in such patients.
Okay. So my other question is that when you inject cement, you said that we don't use pressure. Yeah. And do you have to inject cement a little earlier so that you get the pores, the cement across the pores?
Yeah, correct. When it is not purely liquid, but not purely semi-solid also, we can start injecting, because initial first cement will be contained inside the vessel itself. Then second, we have got 2 mechanisms. One is we can just go on injecting like vertebroplasty, what we do. Second is there is an assembly like kyphoplasty also. So if you add, you just go on rotating the thing, and every 4 turns will deliver 1 cc of cement. Okay. So every time you do 4 turns, it delivers measured 1 cc cement. And every time 1 cc is injected, you will have 10 to 15% of height gain.
Okay.
So that is controlled. It is in your hand. How much you want to gain height. And once height is gained, and if there is no posterior collapse or there is no posterior breach, then you can allow interdigitation also. So either to interdigitate or use it as a simple vessel or a simple kypho or simple vertebroplasty. All these variables you can decide on table with online and with CM pictures.
So like a Foley's catheter, is there a predefined volume for each size of the implant?
This is predetermined. We have 20 millimeters implant, 25 millimeters implant. And
so for each implant, do you have the volume of cement defined?
Yes. So basic volume for 20 is 2 cc, for 25 is 2.5 cc, and for 30 is 3 cc. So up to 3 cc, even if you inject in a liquid stage, it is not going to come out.
Okay.
And after that, the implants start expanding.
Okay.
And then depending on what you see on the C-arm, if there is a posterior wall breach, then naturally you want more stability. You also inject 1 cc or 4 tons more, so that you just inject 1 more cc to have interdigitation. So that implant doesn't become loose and doesn't leave the vertebral body, or it doesn't come on the in touch of spinal cord. So in burst fractures also you can use this.
Is it really a costly implant, sir? Or
no, it is exactly like cost currently is exactly like kyphoplasty, but we are trying to bring it down. Cost is
okay
because now this company has been taken by American company, so naturally they have their own business modalities also. But I think once it becomes popular, the price can be brought down.
Okay.
So you use 2 vessels or 1 vessel?
You can do either way, no problem. That is why I said we did 1 vessel, we did 1 extrapedicular in lumbar. Biomechanically, it gives similar results.
Okay. So you think that it slowly would replace kyphoplasty?
Yeah, because it is a better philosophy, better implant and safe implant. And it is in your hand till last moment, till the cement sets. How much you should expand, how much you should inject the cement. Everything is under surgeon's control. So I think that is a better option.
Yeah. So from Dr. Bhave's talk, the take home is that a new procedure, vesselplasty, which incorporates a lot of benefits of kyphoplasty and gives some of the benefits of vertebroplasty as well, is the new thing that is going to be useful, and it might have a place in improving the treatment of the OCF non-unions.
Yeah, and you can combine it with percutaneous pedicular fixation also, where you want anterior column reconstruction along with posterior stabilization. So all permutations are possible. Number 2, I am happy because I have gone through all the 3 generations of this idea. I started with vertebroplasty in 2000, and then went to kyphoplasty, had my own failures, and then went for everything. And this research we are doing in animals since 2005. And finally, after 12 years, we have come to US patent, because we had to submit to US government 5 years clinical trials. And everything has been done. All the results have been submitted, and after that we have got EU also. So it is US FDA approved, EU approved. So it is, I think it has gone through all the tests. And I had an opportunity to develop an idea, work with somebody, work with industry, work with biomechanical tests also. We did a lot of experimentation in rats and other things, mice also. And now that is why we are coming up with biodegradable implants, which has been approved now in Hong Kong also. So we have started using biodegradable implants.
There is a question in the chat box. There are no any questions. I think thank you, Dr. Bhave, for enlightening us with the new procedure. Now we proceed further on to the next talk by Dr. Sailesh Hadgaonkar on tips and tricks and avoiding the complications in the procedures of vertebroplasty, kyphoplasty. Over to you, Sailesh. Can you please start the presentation?
Hello, everyone. I would like to thank the ASSI core committee for giving us the opportunity for this osteoporotic fracture workshop. And today my topic is tips and tricks to avoid complications during surgery for osteoporotic vertebral compression fractures. When we think about osteoporosis, it's always there in our head that this is a medical disease, and this is the most important thing, that every one of us treats this, and if you don't treat these patients medically well, you will not get outcomes. And this is the most important thing. It's a medical disease. Always understand we have to consider treating it appropriately, pre-operative and post-operatively. When this patient with multi-level fracture comes to us, We have all the options: bracing, medications, rest, vertebroplasty, and stabilization. We have to have the most important thing to avoid problems and complications is to have your proper indication. Most important, absolute indications, and maybe sometimes some cases where we have to take some special indications in situations. We will be going through them one by one. Surgical options, we always think about the vertebroplasty, kyphoplasty, which is percutaneously done procedure, and the other options are instrumented stabilization. What is the ideal indication for vertebroplasty, and what time we should do, and how much cement we should inject? All these things are there in common mind, and we are always confused because someone shows a lot of cement injected, someone shows less injection, and all these things are always a puzzle. Most important is the procedure. We have to have absolute anatomical understanding about the pedicle, where we are going, what direction we are entering from for the probe and trocar, and how much cement we are injecting and where we are injecting. This will avoid a lot of issues because vertebroplasty, though it's simple, it's known for a lot of complications. Vertebroplasty can have leakages, embolization problem, and so emboli problem, and so on. Selection, as I was talking, and these are the patient who will have issues medically. When we see a patient like this with non-Hodgkin's lymphoma, multi-level fracture, and there is significant pain at 4 to 6 weeks, she is presented to us, and we see a L1 fracture, she's not been able to lie in bed, medicines are not helping. And this is where we need to think whether we can get a good vertebral augmentation by cement or the kyphoplasty. This patient is referred by oncologist, therefore there is PET scan and all these things. And we see that this patient was treated with vertebroplasty in L1, and we can see the cement linear leak which is coming into the pedicle. Luckily, there is no extravasation of cement anterior, lateral, or in canal, but this is one important thing when we should take out the cannula. All these things are important. We should try to understand if you put the cement and inject it very harshly or in fresh fractures, there are chances of cement leakage in posterior aspect, and it can lead to devastating complications. We have had a case where the patient was referred to us where there was cement injection was done at dorsal spine, lower dorsal D11, and the cement was into the canal. Patient had monoplegia, and these things are very, very difficult to treat. We did decompression of that patient, but all these things we can really treat it well without creating much complication. These complications are worldwide, and we see that there can be pedicle burst, there can be a medial entry into the canal. All these things can lead to issues which are not required, and therefore C-arm, a good C-arm and checking it in AP lateral is very, very important. 3 questions are always there: where we should inject the cement, how much we should inject, and these are the things. And safe deposit area, if you see there, the anterior third is the most safest area. Anterior third to the mid half, mid third is the good area for cement injection in vertebroplasty. We always prefer not to inject in retropulsion on CTMR, cortical breaches. It's not a good indication because they can leak out. And the basivertebral venous plexus is very strong, which can lead to various devastating complications, as is mentioned in literature. Cement consistency, when it is doughy, you should start injecting like a toothpaste consistency, and always wait till it completely sets without removing the needle. Always confirm the levels in, use the dye, always confirm it in AP and lateral, and it should not go very fast because flow rate, if it is higher, it can cause extravasation. That's also not good. We use this gel foam embolization technique, and we have published our series for safety of cement leakage, and this is what we realize, that it can really cause devastating issues. The vertebroplasty can cause like the embolism, acute respiratory failure, intracranial embolic stroke, and things so on. Things related to complications in osteoporotic vertebral compression fractures, there are many. It's always to understand the preoperative issues, intraoperative and postoperative. Always know it better, always supplement the patient better and treat it better. That's the preoperative plan. Intraoperative, always understand the number of anchor points. We should always prefer a longer constructs for thoracic and thoracolumbar. In lumbar nowadays, because of the vertebral augmentation, we are trying for shorter construct with vertebral cement and screws, cementing and screws, or PMMA coated screws in lumbar spine. We should always protect the construct post-operatively appropriately. That's important in Indian scenario. As we always understand that this is something which is a medical disease, needs to be treated appropriately along with your surgical treatment. Let's talk about the case base. This is a 70-year-old lady, back pain, was treated by orthopedic surgeon for a good some time, and she was suddenly worsened and comes to us with inability to stand and walk. And in lying down, she is 5x5 and she cannot stand and walk. There's dynamic instability, buckling collapse, and we can see that there is thoracolumbar instability. And in such patient with minus 4.1 score, we prefer longer construct. And in this case, if we realize we did 4 levels above, 3 levels below, and this is important for such porotic patients. Length of the screw is very, very good. If you see, these are the hydroxyapatite coated screws, and we really got a good outcome, and this is almost a 2-year follow-up. Additional supplements like hooks and wires and cables are really useful, and they can be used as an adjunct in osteoporotic fractures, and we have to keep it as a backup in all the possible cases when we are treating osteoporotic spine fracture. And again, a long construct where we are using these dual core screws nowadays a lot, and these are of a great help. We use this smaller length in the porotic fractures, and we use a longer length in the above and below construct. And really, if you see, the sagittal contour is significantly better. This patient is doing really fine at 18-month follow-up. Pedicle screw fails due to toggling, loosening, metallosis, and eventual pull-out. All these things are very, very difficult to treat because even the above levels are osteoporotic. Therefore, we need to understand the screw characteristic, the insertion techniques, and bone quality to give our best in this dilemmatic spinal issue. The screw design, as I mentioned, just the dual core screw, the dual core screws are better in terms of higher insertional torque, higher fixation strength due to increased thread density in the pedicle area, and we are really happy with our experiences in this. Most important is how you are putting the screw and how long the screw should be. Around 80% penetration really increases pull-out strength by 32%, and this is a Craig et al. Paper, which is really very, very important that if you put a smaller length screws, really you are not going to get a good outcome. There are high chances of pull-out and you will land up in trouble. To avoid this, it's always better to have a longer length screws. The direction, the conversion angle should be 30 degrees, and it really gives a better pull-out strength by 28% over parallel screws. And this is very, very important. We all should understand. We all have this experience, and always checking, confirming. I'm saying again, in AP lateral, if you have O-arm, it is very important. Any modality which you are using, always go for a properly convergent screws. And even thoracic spine, the angulation really helps us in significant way. The trajectory, the insertion angle, whether it is straightforward technique, gives 27% pull-out strength than the anatomical. And yes, this is again something which is spoken about, but nowadays people are talking about bicortical or screws towards the end plates. They are having more better, stronger support. And tips to increase the pull-out strength, if you realize that the bicortical insertion really helps us for avoiding any issues of pull-out and things like that. Hole preparation, again, this is very, very important. Little bit versus probe, no difference in pull-out strength, but if your holes are slightly bigger while doing some issues or tapping, again, it's a problem. Because tapping itself is shown that it increases the volume by 27% and decrease the pull-out strength by 8%. Therefore, we always prefer to under-tap the screws in osteoporotic fractures. It is better always, and it really helps us in better stabilization. Cross links, most important that cross links are a big adjunct and support in osteoporotic fracture. It increases the torsional stiffness by 44%. The single link and additional second cross link helps by 26%. And in osteoporotic fracture, they are definitely recommended. Always important is that do not stop at junctional level, and you will have a PJK, and that's again a nightmare and trouble in osteoporotic spines. We always see issues in PJK and DJK in osteoporotic fractures if you stop at a wrong level. Pedicle screw with support of cement augmentation or PMMA, hydroxyapatite, all these are coming in vogue, and they are worldwide getting a lot of popularity as they help us by giving better patient outcomes in long term. Pull-out strength of pedicle screws with cement augmentation in severe osteoporosis, and if you see, a lot of papers are coming with this, supporting this newer techniques. And this is a kyphoplasty and in cement augmented pedicle screw in a 97-year-old patient. This is a wonderful thing which we are giving a good life to someone who is expecting a better quality of life. And this is, I will say, a very good outcome in this paper. Ideal pedicle screw, what is ideal? There is something like that. This is a 65-year-old patient, fall from height and osteoporotic fracture. The porosis was always there, and there was a fracture which was treated conservatively, but the patient started worsening and weakness, sudden weakness, and this patient is with us. We have no option but to offer the surgery for this, and we did 3 above and 2 below construct and doing decompression at that level. This is through O-arm. They are all different ways to skin a cat, but most important is a good anatomical support will give you a good outcome. We got a very good outcome in this particular case, and it was treated very, very efficiently at the right time. Therefore, this patient gotten better. 72-year-old man, again, case-based scenarios I'm talking for giving some normal advices, suggestions. The patient with bilateral hip weakness and buckling while standing, 2-level fracture, L2 and L4 with L1-2 disc, again severe porosis. We did a cement augmented screws and decompressed, and this patient really did well. Augmentation by implants such as laminar hooks and sublaminar wire have shown very good outcomes, and our experience with sublaminar wire is very good. Lamina is the last thing to have osteoporosis, and they really, in this particular case, we have used the sublaminar wire for revision, and as this patient was in a lot of pain, the tulips were painful, the patient was skinny, as you see this, and sublaminar wires really are a surface fixation. They really hold the lamina, and the wires are called as Bhoj wires because Dr. Bhojraj popularized it in India. And sublaminar wire construct really gives a good osteoporotic fracture treatment. And we should understand while putting the screws, this is a very, very good technique where we can advance it above and below 2 to 3 levels, 4 levels, and we can get good surface fixation. And these are our experiences, and this is a revision spine which we dealt with the sublaminar wire. Expandable screws are something which are really of a great help, and they are coming in market recently, and they have a great peak pull-out forces than standard pedicle screws. Again, cortical bone trajectory are also used by a lot of surgeons for better pull-out strength in osteoporotic fractures. In special situations, patient with back pain and sudden worsening, or known case of CS cervix, these are the cases where we have to understand we need to have an anti-risk support as well. This lady was with weakness in the lower limb, hip and knees were weak, and where we had no option, severe osteoporosis, we had no option but to decompress and stabilize anteriorly as well. We did decompression 3 above and 2 to 3 level below with anterior cage, and really we got a good outcome in this particular case. So anterior support is important in cases, selective cases in osteoporotic fractures. Dual core, again, very, very useful nowadays in most of the osteoporotic fractures. Any implant back out, this was osteoporotic fracture with stenosis, was operated elsewhere and comes with back out of the implant because probably they stopped at a wrong level, junctional level, and at the apex of the deformity. And these are the special situations where we need to consider advancing the spine at higher levels. We use the demineralized bone matrix for fusion, and this is where we keep the midline intact, and we've advanced the level 3 level above, and this patient is doing fine for last 2 to 3 years. And the last case I would like to talk about the sacroiliac fixation in osteoporosis. This is a patient of multiple myeloma with multiple fractures, sudden worsening with coda equina and severe disability. If you see, there is a large disc at lumbosacral spine, and he was undergoing treatment for more than 1 year or not getting better. Inability to sit was his main concern, and he suddenly worsened over the period of 4 weeks. And multi-level fractures where we planned for decompression and stabilization completely. And this patient really did well. He went for a bone marrow transplant later, and he's doing fine. This nearly 3-year follow-up we have. These are the things which are important in osteoporosis, where we can fix these kind of multi-level fractures with appropriate lengths and always go above and below. And this is where we really got better in we did D10 to S2, and this is the important thing, that appropriate levels are very, very important in selective cases. The other thing, surgical pearls. Prevention is the most important thing in osteoporosis. Prompt referral to an endocrinologist, again important. Longer fusion in general is the key. At least 3-point fixation above and below the apex of deformity should be used. Hybrid constructs really help in special situations. Iliac sacral fixations in long fusion are recommended when feasible. Anterior column support increases load sharing when required. The direction of pedicle screw insertion affects the pull-out strength. Under tapping always increases the insertional torque, and hubbing of pedicle screws adversely affect the pull-out strength and should be avoided. These are the important 10 pearls in osteoporotic fracture fixations. And I am sure that every one of us really face this challenging nightmare, and I hope this helps you in some way. Thank you very much for patient hearing.
Thank you, Shailesh, for a very detailed account of the possible complications, tips, tricks, and the precautions we need to take. Now it's open for questions. Can I start with the question?
Yes.
When you set out to do a fracture, your patient is having osteoporosis. So what are the things in the implants that you keep, everything ready on the table? What are the things that care you take to make sure that, you are not stuck because of lack of proper implant?
Yeah, our experience is with this is there, when we see that there is a porotic patient and we can land up in trouble. Sometimes there can be a pedicle fracture or, inadvertent issue which happens during surgery. We would always keep sublaminar wires as a backup. That's number one. Second is we can keep hooks also. So, that is also a laminar hook or pedicle hook is important in certain situations. And always keep it in mind that we may need a longer construct to extend above or below. Choose your implants wisely. We always keep these days we are using dual core, but previously we used to do the cement augmented screws. So always keep everything as a backup on your trolley that they are available. Length of the screw, whatever the length in predetermined X-rays, you should keep it. Otherwise, you should not land up with only 4 or 6 screws are there of 40 size, and then there are 35. All these things are not important. We have to have a longer screws for bicortical purchase if you are not having a dual core screws.
So we have these different types of screws to improve the purchase on the bone, like the HA coated screw, or where you put the cement first and then put the screw, and the where you cement impregnated screws, where there is a channel to inject cement into the with perforations at the end of the screw. Out of these, in your experience, and the dual threaded, of course. So, what in your experience, which are the most the best ones, from the purchase point of view?
No, I think if the patient is with very severe porosis, I think cement augmented screws are, in comparison, are very strong, if at all. But in routine porotic cases, we use dual core. They are very, very good, and there is not much of a mixing of too many things, putting cement and then using the screws. Dual core really holds very well, and we do not compromise on any loose screw at any given time. That is the most important thing. Sometimes, as a surgeon, we are sometimes we feel accept it and okay, things will be fine because we have other levels. Never compromise on accepting a loose screw. And I think these two screws are giving very good outcomes so far in our practice.
Okay.
We are running short of time, so if you could go to the next lecture, please.
So next is my presentation on the medical management of osteoporosis. Can we run it on, please? Osteoporosis, being a medical disorder, requires medical management, and it's indicated in patients who have very low T-scores and those presenting with insufficiency fractures. Now, amongst the drugs, calcium supplements are the building blocks. Vitamin D3 is the catalyst. Then we have the osteoanabolic drugs, teriparatide, abaloparatide, and romosozumab, and the anti-resorptives, which consist of bisphosphonates, denosumab, and other drugs which are less efficient and not much used now. Now, calcium supplementation is the most important. They are the building blocks, part of hydroxyapatite, and if it is itself deficient, the other therapies would be less effective. Elemental calcium in doses above 1000 milligrams are required depending on the age of the patient. Calcium alone is not sufficient. Vitamin D3 and calcium act in tandem, and D3 doses of weekly and monthly regimens are as good as daily regimens, and is proven, and monthly and weekly regimens give better compliance. Daily requirements 800 to 2000 units, no consensus. Now the important thing is that deficiency of vitamin D3 can cause hyperparathyroidism, which is not a good environment for the bisphosphonates to work, and they become less effective or ineffective. Now the other important group of drugs is the osteoanabolics, which are bone-forming agents consisting of the well-known teriparatide and the newer drugs abaloparatide and romosozumab, which are probably not yet available in India. Teriparatide is a form of parathormone which stimulates osteoblasts, reducing the osteoblast apoptosis and improves the bone architecture, and it is a positive anabolic drug. Abaloparatide, similar to teriparatide, supposed to be more potent but has a little more adverse effects than teriparatide. Romosozumab is a completely different entity. It is a human monoclonal antibody which inhibits sclerostin. Now the role of sclerostin is to inhibit bone formation, and sclerostin is released by osteocytes as a regulatory mechanism. Now romosozumab, as shown in the figure on the right side, it blocks sclerostin and thereby promotes bone formation. Potency-wise, romosozumab is higher than abaloparatide, which is in turn higher than teriparatide in efficacy. The osteoanabolics have limitations. All are injectables. They have a short tenure of usage of 1 to 2 years due to significant adverse effects, malignancy in case of teriparatide and abaloparatide, and significant cardiac intolerance with romosozumab. The anti-resorptive group of drugs, bisphosphonates and denosumab being the main ones, are most important group of drugs in the treatment of osteoporosis. The bisphosphonates work on active bone surfaces. As shown in the figure, they are ingested by the osteoclasts and they reside on the bone surfaces. They decrease the ruffled border of osteoclast and thereby reduce the efficacy of osteoclast in bone resorption and thereby help in preventing resorption of bone. They stay in bone for about 10 years. As opposed to that, denosumab has a different mode of activity. It is a rankle inhibitor. Now, rankle is released when there are a lot of osteoblasts. The rankle goes and attaches on rank, which is this on the surface of osteoclast, stimulate the osteoclast to cause bone resorption. So by blocking rankle, it blocks bone resorption. The other drugs are not much in use now. Calcitonin is limited to use as analgesic in osteoporotic vertebral fractures. Now, bisphosphonate action starts within 3 months of usage. It's recommended for use up to 3 to 5 years. It has less incorporation in cortical bone and more in the cancellous bone. So it is more effective in the spine rather than the hip. Therefore, a long-term impact on osteoclast lasting for 10 years, and therefore young patients it should not be used. Drug remains for a long time after stopping, and the efficacy also remains, and that is why it is possible to have a drug holiday after stopping bisphosphonates, available in oral and IV forms, but IV form is more effective and the effect starts faster. Amongst the oral bisphosphonates, alendronate is the best effect on bone and spine, whereas zoledronic is the best amongst all the drugs, and it can be given only intravenously. Now, comparing denosumab with bisphosphonates, denosumab not necessarily acts on active surface. It acts on all bone surfaces. It has a proven superior efficacy than bisphosphonates. It has superior effect in naive as well as pre-treated patients. It can be used for up to 10 years. Injection is used once in 6 months. But the important part of denosumab is that on stopping, there is severe rebound osteoporosis, and therefore it has to be replaced by another drug after stoppage of denosumab. Now, among the strategy of drug usage, calcium and vitamin D3 have been proven to be the most important part of treatment, irrespective of all the other drug used by all studies. So usually it is a trend to start calcium and D3 along with the oral bisphosphonates because of this gives the maximum patient compliance, and injectables are a little less liked by patients. But it is important that it should not be guided just by the ease of use. It should be guided by bone marrow density, bone mineral density, and fracture risk in that given patient. Osteoporotic disorder spans over several decades, but drugs have limited time usage defined as of today. Therefore, combined and optimum use of drugs is very necessary. Being stingy in use of drug is helpful for the patient in the long term, because then you can use for the maximum period possible. And so we have sequential monotherapies of using one drug after another, sequential add-on combination therapy, as well as combination therapy of starting drugs together. Now, these drug combinations have been studied extensively in literature. Results are different and distinct for different strategies. There is no mathematical formula as far as drug combination goes. And injudicious use can lead to an irrational therapy and can have a bad effect on the patient. Also, it's important to note that treating a naive patient is better than treating a patient who has already been given some drug. And that's why it is very important to make the right choice right in the beginning. In moderate cases with moderate fracture risk, one can start with calcium D3 and a monotherapy of anti-resorptives, either denosumab or bisphosphonates. And the choice depends on the extent of the bone mineral density loss. And this response can be monitored by 6 to 12 months. The indications for using osteoanabolics is a patient presenting with a fresh insufficiency fracture, an insufficiency fracture occurring in a patient already on anti-resorptive, and established osteoporosis with very low T-scores. The important thing is that the duration of treatment should be preferably 2 years, but at least 1 year, because shorter use of osteoanabolics can be ineffective. Now, once you have started a monotherapy, and if it is effective, you can continue monotherapy for the tenure that it is defined for the drug in use. And once the tenure is over, you switch over to another type of drug. However, if the monotherapy is not effective, then it is necessary to switch the drug or add another drug. Now, switch over. If alendronate is used, you can use zoledronate or dimab. If zoledronate is used, you can use dimab or teriparatide. And if dimab is used, you can switch either to zoledronate or teriparatide. Now, one can also add a drug. So since we are already using an anti-resorptive, it will be necessary to add an osteoanabolic drug like teriparatide, which can be added to bisphosphonate or to denosumab. But another anti-resorptive cannot be added when an anti-resorptive is going on. So dimab to bisphosphonate and vice versa is irrational therapy. Now, it has been proven that if you add teriparatide to an inefficient bisphosphonate or denosumab treatment, it gives better result than completely switching over. So at a point of time, if you find the therapy is ineffective, it is better to add teriparatide to bisphosphonate or denosumab. Combination therapy of teriparatide or rather osteoanabolics with antiresorptives have also been studied. Teriparatide with bisphosphonates is not very effective because bisphosphonates can blunt the effect of teriparatide. Teriparatide with alendronate has shown no benefit. Teriparatide with alendronate added after 9 months has been shown to have some benefit. Teriparatide with zoledronate, initial result good at 6 months, thereafter no benefit. But this combination has the best of both worlds because teriparatide is effective in spine and zoledronate is effective on hip. But overall, teriparatide bisphosphonate combination is not a very desired combination. Teriparatide with denosumab is a very hit combination. At present, it is the best combination for treatment of the most severe cases. Some authors have used 40 micrograms of teriparatide instead of 20. And this combination even increases the BMD in the radius. So this is the most effective combination treatment for the most severe cases, teriparatide with denosumab. Now, when the monotherapy ends, then depending on the primary drug and the duration of the primary drug, you have to choose the next drug to continue the treatment. So if you use bisphosphonates, they have the property of giving a drug holiday. So you can have no drug for 1 to 2 years and then start teriparatide or denosumab. If teriparatide is used, continuation with bisphosphonate denosumab is a must. It must be continued. Now, denosumab is notoriously known for fall in DMD as soon as the drug is stopped, and therefore bisphosphonates must be started within 6 months following stoppage of denosumab. The best of these lot is alendronate followed by zoledronate. Switch over to TPD from denosumab is less effective. Now, there is emphasis on all the drugs used. However, the non-medical management also carries a lot of importance. Exercises, walking, weight control of comorbidities, fall avoidance, early preventive management to maximize peak bone loss are the ways to treat osteoporosis non-medically as well. Now, in the summary of medical treatment, calcium and vitamin D3 are the pillar stones of treatment. Several drugs with different modes of action are available and they are broadly grouped into anabolics and antiresorptives. It's essential to know the group of the drug to make a rational combination of drugs. All drugs are tenured based on the available research. The knowledge of this helps in maximizing the duration of use. Appropriate switchover therapy at appropriate time is very important. Knowledge of effective combination drug therapy and sequential therapy is necessary to treat more severe cases. Osteoporosis is a disorder lasting over 3 to 5 decades. As of today, including drug holiday, we have drugs that can be used for 19 years as far as research studies have shown. The newer drugs, romosozumab and the more potent parathormone analog abaloparatide carry more hopes. However, further more drugs and drug tenures will be required for treatment of this disorder, which is lasting several decades. Thank you.
Great talk, Dr. Badani, and detailed representation of the medications. As there is always a confusion which medicine we should use, and a lot of time we are puzzled, and this is a very, very clear-cut guidelines which you have told us. I would like to ask Dr. Dalvi's experience about medical management of osteoporosis. Yes, Samir sir.
So honestly, what happens is the very basic ones, I treat them, and I get a basic metabolic workup. I'll get their bone density test. I'll just make sure that they don't have any other disease, and look at the basic biochemical parameters. Their vitamin D, B12, calcium, PTH. It's very important to look at PTH because you don't want to start teriparatide on these patients. And then based on medical measures like some other measures like calcium and vitamin D, of course, proteins. I give them advice on weight-bearing exercises, etc. But only if they have established osteoporosis. If they are minus 2.5, would I start something? And if it's minus 2.5 and no symptoms, I start them on denosumab because it is very friendly. Just once in 6 months. Yeah. And if it is minus 2.5, with a fracture or minus 3.5, then I would prefer teriparatide. It's a bit patient unfriendly because of the daily injection. But and the parathyroid hormone should be low. Like they can't have hyperparathyroidism. Then I prefer teriparatide. I personally don't give the SERMs or some of the other things because I don't have experience with them. And at any point I feel it's getting out of my hand, I just refer the patient to an endocrinologist. So I don't go beyond these drugs. Even the medical measures like even the simple measures like weight bearing exercise, protein, etc. is very important. And then I monitor them. I would do another DEXA at 6 months, another one at 1 year. But if I feel it's not working out, I don't hesitate to involve an endocrinologist. Because I think bone density management is very, very important for the patient.
And which basic advices you would like to give it to the patient of this along with the medications?
Calcium intake, both pharmacological calcium as well as dietary, give them advice on what foods to take, etc. Sunlight exposure. And weight-bearing exercise is very important. So I ask them to go for walks initially. And then later on, I ask them to get anklets and, they get weights, ankle weights and this weights and go for walks with them. And, then maybe if they are able to do a bit of running, but the elderly can't do it. And then a little of dumbbells. Protein is very, very important, especially our patients are very protein deficient. They're all protein deficient. So you have to tell the vegetarians, you have to tell them, the vegetarian females, soya is very good because it helps them with their postmenopausal symptoms as well. The vegetarian males, you shouldn't give soya. But then, dal, cereals, etc. and protein powders, actually protein powders, protein supplements. And for the vegetarian, non-vegetarians, of course, you tell them about protein. Like medication, I told you, I used to initially, I still sometimes give oral, osteophos, which is the best, alendronate, because I believe it's better than the other ones and safer. So alendronate 70 milligram once a week. Okay. If not, then denosumab, which is just one shot in 6 months. It's very easy to give to people because they don't get any GI effects and they don't forget it. It's like once in 6 months.
Correct. I think what happens in osteoporosis treatment, patients normally don't follow it for a longer period. Generally, after 6 months or so, they will change over or they'll change the doctor or things like that. Therefore, we normally, very few patients will religiously take teriparatide for 2 years. In most of us practice, we see that they take it 1 year, 1.5 years is maximum they tolerate, and then they want to change. And the change is good when this denosumab covers up for, as Dr. Badani has mentioned about the holiday. It's very painful to take the injection every day. So that is one thing. But teriparatide has shown very good outcomes in treating osteoporosis per se. Any other inputs from you, Dr. Ankur Nanda?
Just, what Dr. Samir was saying, that he doesn't feel shy to shift over to other therapies and he measures bone density. But our experience with bone density has been a little bit dicey in the sense that even if you start teriparatide and these, especially teriparatide, it doesn't really translate into a very good T-score improvement. And so that is why we usually rely on the symptomatology and the improvement of the patient clinically and do not try to monitor it with the DEXA. DEXA is good to actually initially screen and take a estimate of how bad a problem we are dealing with, especially in the scenario when there is no osteoporotic fracture. If she has an osteoporotic fracture, she's severe category and in my books will be treated with a teriparatide. But if the osteoporotic fracture is not there, osteoporosis is there, then DEXA is good to quantify at least. But we find it very poor to actually follow these patients up for the result.
Yeah, I was in one of the endocrinologist society webinar, and there was a discussion going on that osteoporosis per se doesn't cause pain. It is the osteoporotic fracture which causes pain. And about DEXA also, when there is a patient who is elderly and maybe 60, 65 and there is a fracture, in general, even if you don't do the DEXA scan, it's fine. It is considered as osteoporosis. So what is your take on it, Ankur?
I would actually agree a bit and disagree in the sense that I think osteoporosis itself is responsible for the pains which we see. We know that, these patients, they come with a lot of pain, generalized body ache, especially in the lower part of the ribs. The ladies will complain a lot of lower part of the ribs pain, subcostal pains. And once you give them teriparatide and follow them at around 6 to 7 months, 8 months period, these pains have magically gone away and they are feeling very, very healthy. So I think I would think the other way, that it is not only the fractures which give pain, but the bone weakness itself, which is causing microfractures inside, is giving a lot of symptoms.
Yeah, one last question. Dr. Ajoy Shetty is there. Dr. Ajoy?
You can use calcitonin spray in such cases. I have tried it. Even if you use for 1 month, only thing is they should not be suffering from any malignancy.
Yeah, Dr. Bhave, I just would like to ask one last question. When we see this patient with osteoporosis, what all precautions you want to take? Sometimes it can come out as like tumor or anything else. As you mentioned in one of your cases where you were doing vertebroplasty, you aspirated and there was pus. So what are things you want to give us, your advices, suggestions with your vast experience?
No, first thing is there should be, when we are talking of osteoporosis, we should rule out other causes. So secondaries, and in Indian references, tuberculosis is always we should worry, because tuberculosis mimics anything and all other diseases. So that should be always in your mind.
Yeah, so metabolic profile, we should always do the basic blood markers, we should check ESR, CRP, and things like that.
Yeah.
It's a very good message. Anything you would like to say, Dr.
There are some questions in the chat box.
Yes.
Somebody, Dr. Rahul, says, when do you decide to repeat the BMD?
Yeah.
Dr. Bhave.
Yeah, it depends on it really depends on what you're doing and what you're treating and what you're following. Normally, for elderly patients above 60 or 70, once a year is enough. I don't think you really need to do it much more than once a year. Because, actually the DEXA scan is slightly vague. I'm not sure how precise the DEXA scan is. There are some errors in the DEXA scan as well. And in the DEXA scan, in fact, you can actually get a higher bone density in the spine. But because what happens is that because of degenerative changes and osteophytes, it looks even more dense. So you may not even get the correct idea. Yeah. But once a year is enough, and it's a rough guide. It is not a written in stone kind of guide.
Yeah,
it's a rough guide to give you. So a little deviation doesn't worry. Like from minus 1.8, if it becomes minus 1.9, it doesn't worry me. But from minus 1.8, if it becomes minus 2.7, it worries me.
Yeah.
Okay.
So for that, I had one DEXA readings, and I had Indian age group average. So because in DEXA, what we are comparing our bone with whites or German population. And hence there is always a problem. So we have got another scale where you are comparing Indian bone mass with Indian patients. So I found that quite useful, because initially I was doing a lot of DEXA. When I got this machine, we tried to compare with this, and incidentally I found that these results were more matching with patient symptoms and patient's recovery and response to the drugs. So now I am doing mainly Indian database related test of BMD, and that can be repeated after minimum period of 1 to 1.5 years, because before that you may not get good changes. But downward, if they are going, then we have to change the drug. If they are maintaining or they are going above, then there is no need to. That means whatever therapy you are giving is working well.
Yeah. Dr. Bhave, there's another question which you need to answer. And somebody is asking, is there any literature showing long-term superiority in patient outcomes of vesselplasty over vertebroplasty?
Yeah, I told the advantage, and we have already submitted to US FDA 5 years follow-up. That is why this US FDA is cleared.
No, any long-term showing comparative?
Yeah, so it is only 5 years old, this procedure.
Okay.
So we will be publishing a paper, because we have got enough number of cases now with good long-term follow-up. Okay. So we are making a paper, and soon once it is getting accepted, you can see it. But the US FDA has already cleared, and before 5 years follow-up and 5 years animal experiment, they don't entertain even.
Yeah. Okay. Shailesh, you can take this one question that has come up. How to decide the endpoint of cement injection, and how to decide what volume of cement is enough in vertebroplasty?
Yeah, a very good question and important question, because various surgeons have different experiences. And our personal experience with this is mainly for thermocoagulation and giving some mechanical support. So around 2 to 3 ml is good enough. And okay, you can definitely inject more, and there is no end to it. But it's a pre-decided thing that I personally prefer 2 to 3 mils is good enough for 1 level vertebroplasty.
Okay.
Yeah, I completely agree with Shailesh. The principle now is less rather than more. Yeah. In the past, when I started this, we used to really want to see our vertebrae completely white. But now I'm very happy to see this thing. So if you do a unipedicular approach and you've got a little blob of cement in the middle, because your tip of the needle should be in the middle of the vertebra, gone across the midline, then that's good enough. And if there are any sort of clefts or horizontal fracture clefts, even if you just fill those fracture clefts and have a little cement, it's good enough. You know, because there is some, like he said, chemical effect to causing pain relief. See, you must understand one thing. A vertebroplasty has only one role. It has only one role. The role is pain relief. It has no other role. The reason we are doing any of these so-called augmentation procedures is for pain relief. So you have to do really the least or the optimal for pain relief.
Yeah,
you don't want anything else.
Is to establish a bridge of continuity between the segments.
And stabilization, that is mechanical stability. You are holding the two fracture ends together like any other fixation of fracture. There are biomechanical lot of studies about how much cement should be injected. And technically, even we have done our cadaveric experiments, and in engineering colleges, we have done on the cadaver models also. So technically speaking, not more than 30% of the pre-fracture volume, if you inject cement, then that creates strength equivalent to its pre-fracture stage. So anything above 30% of volume will make it hard like a cricket ball, and then you have more adjacent fractures. Now we have got a well-documented series of 375 cases followed over 5 to 8 years with only 2 osteoporotic vertebral fractures. So I think this study definitely backs up. So we use cement up to 30% in vertebroplasty of the pre-fracture volume. We don't know the pre-fracture volume. So what I do is you do CT or MRI of the say vertebra above and vertebra below, because at thoracolumbar junction you have a problem. Thoracic vertebra is a smaller and lumbar L1 becomes a bigger. Or if it is L1 fracture, D12 is smaller and L2 is bigger. So you have a golden mean between the two. For Indian cadavers, thoracic vertebrae, about 3 to 3.5 ml is sufficient, and for lower lumbar levels, about 4.5 cc is sufficient. That comes to about 30% of the volume.
Okay.
And then chances of you getting adjacent fractures will be minimized.
Yeah, I think that all the questions in the box have been answered. Any more issues or questions or pertinent points that we have missed?
I think it was a very good discussion because only
a lot of learning points have come. I think if you ask me, osteoporotic fractures, medical management of osteoporosis, etc., is going to explode because we are just getting more and more patients. The age groups, patients are getting older. Every day in the OPD, I have 3 or 4 patients coming in, and sometimes they are at a loss as to what to do with them because they have pain. Some of them, I've seen one patient yesterday who has come from Yavatmal, who has got 5 or 6 fractures, 60-year-old female, so much of kyphosis, and nobody knows what to do. Like, I don't know what to do. I can't even operate her because everything will cut out. And I think what we really need to look at is medical management of this. How bone density can be maintained in human beings as they age. I mean, and there is, of course, research going on. Not that there isn't. There is research going on.
No, one of the important things which was beyond our topic is that preventive measures, the early starting of calcium, vitamin D, which is the peak bone mass, etc. Those, if those are, understood by the general public, its awareness is increased, that can lead to reduction of these problems. Yeah.
So another thing what I do in my practice is once I get a osteoporotic vertebral fracture, I do their osteoporosis study, give them conservative treatment, start with teriparatide if PTH is normal or below normal. And then in a follow-up X-ray, if it shows it is maintaining well, no collapse, I continue conservative treatment. If it shows pain is increasing, radiology-wise it is collapsing, then I advise any augmentation procedure. So that has become my rough protocol because 1 month PTH has already been given. So that gives some anti-osteoporotic chemotherapy value also to the patient.
Yeah. So I think we have overshot the time a little bit, and it was a very interesting session. And I thank all the faculty for a very nice presentation and for giving clarity to all the junior spine surgeons. And I think we'll consider the session as we'll end the session here. And I thank everybody and thank all the delegates who have patiently listened to us. Thank you.
Thank you very much. Yeah.
Thanks all the faculty. Would just like to remind the delegates and everybody that the main conference is going to start. It's on 29 January and we are going to start where we are finishing. The opening session is going to be again moderated by Dr. Shailesh along with Dr. Rajshekharan sir. It's a session on navigation in spine surgery. It's a star-studded session. So see you all 7:30 in the morning on 29th January. And this was a great session. Thank you, everybody.
Thank you very much. Thank you. Yeah.
Can we go offline, please? Thank you, sir. Thank you, Samir, sir.
We disconnect now? We disconnect?
Yeah. Yes, sir.
Thanks, guys.